Welcome back. Hope you can hear and see me properly. If you can hear and see me properly, you can just tell yes. Okay, all right. So you are able to hear and see me properly then. Cool. Okay, fine. So what we are trying to see from now on is moving on to the AK and CKD part. And before going on to the AK and CKD part, let me discuss some few parts about the glomerular disorders. And even before going into the glomerular disorders, it's important to note about the urinalysis for that matters. And more importantly, we also need to know about the markers of renal function and all this stuff. So first of all, we'll talk about the markers of renal functions. That could be the most appropriate to begin with. Renal function markers. So as far as the renal function markers are concerned, first we need to know the physiology of the kidney, and in the sense in a very short way. So let us start with the glomerulus, the same diagram which we drew yesterday. So even though there is a considerable variation in what I'm going to draw, but nevertheless, this is going to be very easy for you to understand. So let us assume this is the afferent and the efferent arteriole. And of course, at one point of time, you are going to result in formation of the renal veins. So let me draw in blue. This is going to be the renal vein. So what's really happening here is first you have afferent arteriole. Then you have an efferent arteriole, which is an arterial site. Basically, over a period of time, it forms the renal vein. And it's like the blood is purified and then it's collected through the vein and it enters the IVC and goes back to the heart. So here, like for example, I have not drawn certain things like here, there will be capillary loops that are coiling around this glomerulus, which is intentionally left over just to make you sure that you understand this concept better. Now, in the meanwhile, you are going to have a sort of filtration. So this process is what we refer to as filtration. And this is something referred to as GFR, glomerular. The amount of filtrate that is formed is what we refer to as the glomerular filtration rate. Then, of course, there will be some element of that tubular secretion. So this process is what we refer to as tubular secretion that's going to happen. And along with that, there will be some element of tubular reabsorption as well. And finally, you're going to result in the effluent that is going to come out. And there will be some amount that will be coming out as urine as well. Normally, if you ask me how much is the glomerular filtration rate, glomerular filtration rate is approximately 125 ml per minute as per the physiology textbooks. But when you come to medicine terms, you should answer it in the range of 90 to 120 ml per minute. So that is the actual GFR that we're going to see. And second thing, what they'll be asking you is what is the renal plasma flow? There is something called RPF. The amount of plasma that is coming into the kidney that is actually getting filtered. So renal plasma flow is effectively 625 ml per minute, but even though it ranges from 600 to 675 ml per minute. But the one that is given in physiology textbooks are 625 ml per minute. So normally, if you ask the glomerulus extraction, so how much is that GFR? It is approximately 20% of the renal plasma flow normally becomes the GFR, which means the extraction capacity of the glomerulus normally is around 20%. 20% of the renal plasma flow is the one that is basically forming the glomerular filtrate, and that is what is getting reabsorbed, secreted, and finally you are going to result in the formation of the urine. So if you ask how much amount is getting reabsorbed, basically, the free water we are talking about. So even though 125 ml per minute of water is formed as a glomerular filtrate, almost 123 ml per minute of water will be reabsorbed back into the glomerulus, into the tubules, and which means urine will be formed only at a rate of approximately 1 to 2 ml per minute. So this is the usual amount of urine that is formed, 1 to 2 ml per minute. This is an approximate number. And you have to, we are taking the entire nephrons into perspective. We are not only taking a single nephron. So how many nephrons we have? 1 million nephrons in each kidney, individual nephrons. And in that 80 to 85% of the nephrons will be cortical nephrons. Only 10 to 15% of nephrons will be something called a juxtamedullary nephrons. You know what are these juxtamedullary nephrons? These are the bigger, lengthier nephrons. And remember, the more the length the nephron is, more will be its concentrating capacity. which means these 15% of nephrons which are more lengthier and deeper that are moving into the medulla are the ones that are going to be very important in concentrating the urine. So they have much better concentration affecting capacity. That's why. So now we need to have a good grasp of what do you mean by a glomerular filtration rate. We need to have a good grasp of what do you mean by tubular function. So we have discussed on the tubular functions already. We're not going to discuss on that anymore. The most important functions of the tubules as such. Let us recap one more time, one final time. The first function of the tubules is something called a solute reabsorption. And of course, in exam, they will ask you what is the marker of solute reabsorption. One of the important marker of solute reabsorption is urinary sodium. And of course, we are going to use something called a FeNA, that is fractional excretion of sodium. And second, we have urinary concentration. And one of the important markers of urinary concentration are the urine osmolarity. And second one is the specific gravity of the urine. Even though urine osmolarity is more important in this perspective and fractional excretion of sodium is more important in this perspective. At the same time, with the third important thing that the tubules do is acid-base balance. Acid-base balance, one of the important markers, especially the distal tubule is the one that acidifies the urine. One of the important markers of this acid-base balance and distal tubules acidification of urine is the urinary pH, which is also a function of the kidney tubules only to a large extent. So urinary pH is very, very important in this perspective. Apart from that, tubules have many other functions. For example, they produce vitamin D also, which is coming from the proximal convoluted tubule because they have this 1-alpha hydroxylase enzyme. Apart from that, tubules are very, very important in potassium homeostasis. Potassium homeostasis, especially again, the distal tubule is very important in this perspective. So we know how to understand the potassium homeostasis. Either you measure the TTKG, that is transtubular potassium gradient, or you measure the urinary potassium creatinine ratio, or you can use the urinary spot potassium as a surrogate marker, 24-hour urinary potassium also. So these are the 5 quintessential functions of the tubules, in which the first 2 functions are the most important as far as the exams are concerned. The solute reabsorption function and urinary concentration function. Apart from that, even other things like acid-base balance, vitamin D synthesis, that is active vitamin D synthesis, calcitriol and potassium homeostasis also plays a very important role in this setting. And as far as the tubules are concerned, even though we test this by solute reabsorption by the urinary sodium and fractional excretion of sodium, you need to know that one fact that PCT is the one that absorbs all the solutes maximally. Like for example, 65% of sodium, almost all glucose, almost all amino acids, almost all phosphorus is basically absorbed by the proximal convoluted tubule only. And in fact, a lot of water, around 90% of the water is also absorbed by the proximal convoluted tubule only. But there is one important electrolyte, that is a calcium and magnesium. This is one exception, which will be predominantly absorbed in the thick ascending limb of the loop of Henle. And the second is your distal convoluted tubule. So these are the 2 areas that are going to principally affect the calcium and magnesium absorption, which means these are the areas that predominantly where calcium and magnesium are getting absorbed, not in the proximal convoluted tubule. So except this, almost all the other solutes are basically absorbed maximally in the proximal convoluted tubule. And more than that, they'll be asking you, there is something called a concentrating segment and a diluting segment of the nephron. So for that matters, this thick ascending limb of the loop of Henle to your distal convoluted tubule is basically referred to as something called a diluting segment of the nephron. These are basically diluting segments of the nephron, especially thick ascending limb of the loop of Henle and the DCT. Why they are basically called as diluting segment of the nephron? Because they are water impermeable. They can absorb only solutes and they are completely water impermeable. That is why these are the typical diluting segments of the nephron. Whereas if somebody asks you the concentrating segments of the nephron, I will tell that it is in the collecting duct. So this collecting duct region is the basic concentrating segment of the nephron and the most important concentrating segment. And this concentration at this area depends on ADH. Remember, they will be water permeable if the patient is having ADH in their body. If they don't have ADH, they will not become water permeable, which means water cannot be reabsorbed unless and until ADH is there. But it's a very important concentrating segment is the distal part of the nephron, especially the collecting duct area. And nevertheless, this area is surely a concentrating segment of the nephron because they are freely permeable to water. Why? Because they are freely permeable to water. Freely permeable to water. Next important point. Remember, but even though the distal part of the nephron is a concentrating segment, especially the collecting duct, but their permeability depends on availability of ADH. If ADH is available, they will be permeable to water. If ADH is not available, they will not be permeable to water. But PCT and thin descending limbs of the loop of Henle are basically going to be permeable to water, and they can be acting like a concentration gradient, because if you remove water without solute, that becomes a concentrating segment. So remember, as you enter the PCT in the beginning, the urine will be isoosmotic only. That's very important. The glomerular filtrate that is formed is basically isoosmotic. And if we enter the proximal convertible, once again, the urine will be basically isoosmotic in nature only. As they move down, they'll become concentrated and they'll become more hyper. And once again, if they move through the thick acetylene limb of the loop of Henle towards the DCT, they'll become more dilute. Why? Because in the thick acetylene limb and the DCT, they are going to absorb only the solutes, leaving behind free water. So of course, they are going to act as a diluting segment. But more importantly, which is affecting the absorption of water in any area. So of course, in the distal part of the nephron, your ADH is important. Apart from the ADH, there is one more thing that is important to absorb water from any site in the kidney. That is the medullary interstitial hyperosmolarity. So you have something called a medullary interstitial hyperosmolarity. So which I'm drawing in green here to make you understand. So that's a medullary interstitial hyperosmolarity. And there will be a common question, how much medullary interstitial hyperosmolarity that you can reach? A peak medullary interstitial hyperosmolarity, that is 1200. So which means even however deep you go, however down you go, this is the maximal medullary interstitial hyperosmolarity that you can reach with the help of the protein juxtamedullary nephrons. Beyond that, you cannot achieve, which means the maximum urinary concentration that you can achieve is also 1200 milliosmoles per kilogram only. You cannot achieve urinary concentration beyond 1200, even in, I mean, how much ever you try, because this is the limit for humans that you can achieve only 1200 milliosmoles per kilogram of medullary interstitial hyperosmolarity as well as the urinary concentration. And who is actually helping in developing this medullary interstitial hyperosmolarity is the thick acetylene limb of the loop of Henle. That's going to be the most important, not the DCT. Thick acetylene limb is the one that helps in achieving this medullary interstitial hyperosmolarity. How? Because of the usage of a transporter called as sodium potassium 2-chlorate transporter. So using the sodium potassium 2-chlorate transporter, they are going to achieve this medullary interstitial hyperosmolarity, which means the sodium that is absorbed will be concentrated in the interstitium, and this sodium that is concentrated in the interstitium is important for absorbing water from the thin descending limb of the loop of Henle and some areas of the PCT. It's very important. Similarly, this sodium that is present in the interstitium is the same thing that is also important for reabsorbing water from the distal part of the nephron as well. Even if there is ADH, unless and until you have this medullary interstitial hyperosmolarity, you cannot really absorb water, which means you will not be able to concentrate the urine. That's what I'm trying to tell. So which means when you give some drug that affects this medullary interstitial hyperosmolarity, you will not be able to concentrate the urine. So which means if I ask you what is that drug that prevents the formation of medullary interstitial hyperosmolarity, what will be your answer? What is the drug that abolishes the medullary interstitial hyperosmolarity? What will be your answer? What is the drug that abolishes this medullary interstitial hyperosmolarity? Yes, of course. Loop diuretics is a classic example which inhibits the sodium potassium 2-chlorate transporter, or simply I can write it as NKCC2 transporter. So once you inhibit this, you will not be able to produce a medullary interstitial hyperosmolarity. If you cannot produce this medullary interstitial hyperosmolarity, you will lose the ability to concentrate the urine. So which means in loop diuretics, you will get an isotonic urine only. which means it will be equal to that of the plasma. You will not be able to produce a hypertonic nor a hypotonic urine. So which means your basic concentrating function is lost. And similarly, like your diluting function is also lost, which means if you lose this thick Asning limb of the loop of Henle, you cannot even dilute because it's one of the important diluting segments of the urine. So you cannot dilute as well. So your urine will be basically isoosmotic in the sense whatever is coming as a glomerular filtrate, that will be the same concentration as that of what is coming out in the as a urine. So it's an isotonic urine. On the other hand, if you give a thiazide diuretic is something that abolishes the that does not abolish the middle interstitial hyperosmolality. Instead, that inhibits something called a NCC transporter, that is a sodium chloride transporter, or we can write in full form itself. This is sodium chloride transporter in the DCT, whereas this happens in the thick Asning limb of the loop of Henle. So you can see that in the DCT, if you absorb sodium and chloride, that has nothing to do with the middle interstitial hyperosmolality. So which means thiazide diuretics are someone who is not going to inhibit middle interstitial hyperosmolality, which means they will have an intact middle interstitial hyperosmolality. Because they have intact middle interstitial hyperosmolality, their urinary concentrating ability is also intact. Urinary concentrating ability is also intact, which means they don't lose the urinary concentrating ability. Whereas the urinary concentrating ability with loop diuretics is basically lost in the setting of loop diuretics. That is the reason why whenever they ask you the free water clearance, there is something called a urinary free water clearance. With loop diuretics is equal to 0, which means they neither preserve nor lose excess. So this is a very important question in exam as well. Urinary free water clearance as far as the loop diuretics is concerned is equal to 0 because they can neither lose excess water nor they gain excess water. It's isoosmotic in nature. So that is why urinary free water clearance is 0. On the other hand, if you have an excess ADH in this scenario, which means they will reabsorb more water. So once they reabsorb more water, the amount of free water that is present in the urine will be less. So the urinary free water clearance will become negative in this scenario. Similarly, if you have a diabetes insipidus suggestive of a low ADH or a low ADH action, in this situation, the urinary free water clearance will become positive because you're excreting more water because you don't have ADH in this scenario. So you have to know 3 conditions. Urinary free water clearance is negative with SAADH kind of scenario where you have excess ADH. Urinary free water clearance is positive in the setting of a low ADH, for example, diabetes insipidus, and urinary free water clearance is equal to 0 in the setting of a loop diuretic use. But in thiazide diuretic, it depends on the action of ADH again. Here you can tell that the urinary concentrating ability is intact because you don't lose the middle interstitial hyperosmolality in the setting of a thiazide diuretic. So these are the basic ideas that we have. And now, because till now we have seen only the tubules, but let us see only 2 important points. What do you mean by countercurrent exchanger and what do you mean by countercurrent multiplier? So only 2 points they might ask you in physiology, that is countercurrent exchanger. So which is actually called as countercurrent exchanger? In physiology, which area of the nephron or which part is referred to as a countercurrent exchanger? It's shocking actually. Nobody is answering. What is countercurrent exchanger? The thick Asning limb of the loop of Henle is what we refer to as countercurrent exchanger, and the vasa recta is the one that is referred to as a countercurrent multiplier. Even though we don't want to go into the depth of the physiology in that. So these are 2 questions that you need to know in exam very commonly. And apart from that, there are some indices of glomerular function itself. What are the index of glomerular function? Glomerulus does a few important things as well. We have not cared about the glomerulus till now, but still we know that glomerulus does a few bit of functions. What they're going to do? If we talk about the glomerulus, they does some 2 to 3 important functions. One is, of course, filtration. To produce that filtration, you need to know about the filtration barrier, which we'll be talking about that in some time. And at the same time, if there is a damage to the glomerulus, remember, if there is a damage to the tubules, we are going to estimate the tubular dysfunction by using FeNA, osmolality, pH, using TTKG. So something will tell you the problem in the tubules. But if there is a problem in the glomerulus, how you identify that there is a problem in the glomerulus? Because glomerular problems will result typically in something called proteinuria. And second, they will typically result in something called as hematuria. That is why these serve as a very important marker of glomerular dysfunction. But there are some few other points that you need to note in this as well. But whenever you have a glomerular dysfunction, so you are going to end up in a proteinuria and hematuria. And that is the importance of understanding the urinary sediments as well. We'll discuss about that later on. But we didn't talk about the most important thing, that is the serum creatinine in the first place. But before understanding that, let us see what do you mean by a filtration and what is the basic understanding of something called a clearance, which we're going to talk about next. So whatever the physiology you need, the most important points I've told you in this particular diagram itself, because I need to explain something before going on to the glomerular disorders and AK and CKD, so that I gave an overview of what all you need to know in this particular setting itself. The most important points. I think the other points like loop diuretics causes ototoxicity, loop diuretics will cause hypocalcemia, hypomagnesemia, and it can result in the depletion of volume status. And all this stuff, it's something you need to know already. So there's no point in discussing those things in medicine, even though if you want, I can tell later on. But right now, no. This is the most important physiology that you need to know as far as glomerulus is concerned. So clearance is something that they will be asking you. What do you mean by clearance basically? So let us take a substance that is getting filtered. Whatever the substance that is getting filtered will be proportional to that of the glomerular filtration rate. We know that. And that substance is going to get reabsorbed. That substance may get secreted. So it's going to have a lot of reabsorption. It's going to have a lot of secretory capacity. It can be secreted back into the lumen by tubules itself. And finally, this substance comes in the urine. How much amount of substance comes into the urine after all this process is what we refer to as a clearance. It depends on how much it's filtered, how much it's reabsorbed, and at the same time, how much it's getting secreted. Basically, you know the formula for clearance, which is typically given as UV by P. Everyone knows that. So what do you mean by U? Here, the urinary concentration of that particular substance. I can tell yes, that is U. And V stands for the urinary flow rate. That is the urine flow rate. That is V. And P stands for the plasma concentration of that particular substance. So here U and P stands for the concentration of that particular substance that you are dealing with. And V here stands for the urinary flow rate. So this is the concept of clearance in the first place. And when you take a second example, let us assume if there is a substance that is getting filtered. And of course, that filtered substance is proportional to the GFR. I know that. How much it's getting filtered, it will be proportional to the glomerular filtration rate. And if it's 100% reabsorbed, if it's going to get reabsorbed by 100%, what is the clearance of that particular substance? What will be the clearance of that particular substance? You have to answer. What is the clearance of that particular substance if it's 100% reabsorbed? Yes, everyone answers right. So this is a very basic, simple physiology. Clearance of that substance is 0. What is the example of that? What is the example of that particular substance? Priya is telling inulin. No, not inulin. Saurabh is also telling inulin. Not sodium. Sodium is there. Like you saw positive clearance of sodium. Some amount of sodium is coming. We told, the example has been told already. I told here in tubular function, the PCT absorbs almost all of glucose, all of amino acids, all of phosphate. Yes, the best example will be glucose and amino acids. In this case, the most important example that we know in clinical practice is glucose. Glucose is the best example of such a substance where the clearance is equal to 0. Suppose if the clearance is positive, then it's abnormal. That is where we call it as a glycosuria. Glycosuria can happen due to many reasons. Even we are not talking about protein here. We're talking about solutes. So we are talking about a solute reabsorption, solute secretion. Albumin is not something that is reabsorbed or secreted. That's a proteinuria you're talking about, Pranavi. That should not be confused with glucose or other solutes that we're talking about. So glycosuria. So glycosuria can be due to like your diabetes mellitus or excessive blood glucose, or it may be due to reduced urinary threshold. There are two reasons. So either due to increased blood glucose or maybe due to reduced urinary threshold of glucose. Increased blood glucose means when the serum blood glucose levels goes beyond 180 milligrams per deciliter. That is where you call it as increased blood glucose with respect to glycosuria. And this happens in the setting probably of diabetes mellitus or some dextrose infusions, whatever may be the case. Very common example is diabetes mellitus. Or it can happen at a reduced urinary threshold. As I told you, when the serum glucose is less than 180, at that time itself you can get glycosuria, even if the serum glucose is less than 180. So this happens in the setting of pregnancy physiologically, or this can happen in the setting of a Fanconi syndrome, which I have discussed already, which is a damage to the proximal tubule. So because of that, you might result in development of early glycosuria or a reduced urinary threshold for glucose, or if the patient is taking some drugs like SGLT2 inhibitors, which can reduce the urinary threshold for glucose. Or very rarely, if you want to know one other cause, you have something called a MODY3 due to HNF1 alpha mutations. So this MODY3 is very typical, and the most common type of MODY is MODY3 only. And one of the very important features of MODY3 is early glycosuria. Glycosuria will happen even if the glucose values are less than 180, or very rarely have some benign forms of like glycosuria as well. That's different. That's very rare entity. So usually whenever you want to tell a physiological cause, think about pregnancy. Pathological means these are three things. If you want to tell pharmacological way of reducing the urinary threshold, that is SGLT2 inhibitor, where you'll have a early glycosuria, because they block the absorption of glucose, sodium glucose transporter blockers. Gliflozins are there, canagliflozin, dapagliflozin, empagliflozin is there. So this is the best example. This is one situation where you can understand this. And the third scenario, what I'm going to tell is, suppose if there is a substance that is getting filtered, of course, this filtered substance will be proportional to the GFR. And if this filtered substance is getting reabsorbed partially, it's not 100% reabsorbed, but it's partially reabsorbed, maybe 50-60% partially reabsorbed. What will be the clearance of the substance? Clearance of that particular substance will be equal to GFR, less than GFR, or more than GFR. That's the question here. Equal to, less than, or more than GFR. If it's partially reabsorbed. Of course, we know that it's getting filtered and it's getting partially reabsorbed after that. So this clearance will be less than that of the GFR. The best example of such a kind of a substance is going to be urea. So that's why the clearance of urea is approximately 40 to 60 ml per minute. That's the basic normal clearance of urea, which is less than that of GFR. GFR is 90 to 120, but the clearance of urea is 40 to 60. Then you have another substance. Another substance which gets filtered. The filtered substance is proportional to GFR. We know that. And this substance is partially secreted, not completely secreted, but partially secreted into the lumen. So what will be the clearance of this substance? It will be less than GFR, more than GFR, or equal to GFR. Yes, of course, this substance clearance will be more than that of GFR. The best example of such a substance is creatinine, even though many other substances are there. That's why creatinine clearance is approximately somewhere around 120 to 140 ml per minute. 120, 140 ml per minute. So that is the example of such a substance. And we have other substances as well. Like for example, you have other substance. Like if a substance is filtered, which is proportional to GFR, this not getting absorbed, not getting secreted, just comes straight into the urine. So what will be the clearance equal to? Equal to GFR, or more than GFR, or less than GFR? This kind of substance. Of course, it's not getting reabsorbed, not getting secreted, straight it comes in the urine. So whatever it's coming in the urine is equal to the glomerular filtration rate. So that's equal, clearance of that particular substance will be equal to that of the GFR. And the best example of this is inulin. So that's the best example where the clearance is equal to that of the GFR. And inulin is still the gold standard for knowing what is the exact GFR. But the one problem with inulin is it's an exogenous substance. It's exogenous, and you have to use continuous infusion of inulin. And to find out the GFR doing all these things is stupid. And only in research centers they do that, only in research laboratories. Apart from that, the usage of inulin in clinical practice is almost negligible. We don't even use inulin as a marker. But if there is a substance that that's getting filtered, and that's proportional to GFR, we know that. And you know, this capillary loops are the ones that are going to this efferent arteriole is the one that's going to form the tubules as such. And you know, 20% is getting filtered, we know that, and remaining 80% is coming, and all that 80% is getting filtered as well. I mean, getting secreted as well. Whatever that is coming through the tubules is getting secreted, completely secreted, fully, which means something is getting filtered, and some substance that is coming through the efferent limb, while coming through the tubules, they are completely, whatever that is remaining is also completely secreted into the tubules. And now you have a clearance of that particular substance. This clearance will be equal to what? Definitely it will be more than GFR. I'm not telling that it will be equal to GFR, but what it will be equal to. It's easy to tell, not a big deal. What will be equal to? Yes, it will be equal to renal plasma flow, which means whatever renal plasma is coming, so 20% is extracted, and remaining straight away, whatever is coming, it completely. So the clearance of that particular substance will be typically equal to the renal plasma flow. There are many substances like this are there, but the classic example is para-aminohippuric acid. So that's a classic example. pH is equal to renal plasma flow, where approximately the clearance of pH will be 625 ml per minute. That's what they will ask you in exam. Clearance of inulin will be equal to 125 ml per minute. That's equal to the GFR. So despite, you know, like the fact that inulin is the best, still we stick on to creatinine for measuring the GFR, for analyzing the GFR. That is because what two issues? I mean, two good things. One, it's an endogenous compound, which means you do not give anything exogenously, and it's cheap, available all the time, and you don't need any continuous infusions. You just need a blood sample. That's all to find out creatinine. So that's why still, even though creatinine is causing this kind of errors, but still creatinine is good because you know, like it is very cheap and it's endogenous compounds. You do not use any exogenous infusions for that. So first you need to know the clearance of the clearance of the compounds. Each and every compound's clearance we have seen here. And based on that, we have three different compounds, if you know. I mean, nuclear compounds are also there. So based on that, we can find out the renography, that is renal scintigraphy. We have a lot of types of renography are there, but the three most common compounds that we use for renography is, you have the DTPA that we use, the DMSA that we use, and we use something called a MAC3. All these compounds are labeled with technetium-99m. So why we are basically labeling with technetium-99m? Because we need to count how much tracer is left, or because this technetium-99m is like a marker. Wherever this goes, it's like you would have seen in movies, isn't it? You tag with some marker. If you tag some person in action movies and all, you tag them with some marker so that wherever they go, you can trace them. So which means these have some specialized functions, but to know whether they are working properly or not, to trace them, we are going to use technetium-99m as a tracer. So that's a common tracer that we use to count to the gamma counter. So that's why we use that. On the other hand, we have other compounds also. For example, I-123 hippuran is there. There's something called a I-123 hippuran. That's also there, which you can use. Or you can use para-aminohippuric acid for the same, but para-aminohippuric acid cannot be tagged with any radionuclide compound. That's why currently we don't use, because again, it becomes very cumbersome. Because we cannot measure continuous serum concentration of pH, or we cannot find out continuous serum concentration, continuous urine concentration of pH. So it's cumbersome. So because it cannot be tagged with any radio tracer, we don't use pH right now. But we have four other markers, which is very costly. That's why we don't do that. Instead, these are very cheap: DTPA, DMSA, and MAC3. Can anyone tell what are the advantages and disadvantages of all these DTPA, DMSA, and these compounds? Anyone? So first, let us see the technetium-99m DTPA, how it's going to behave. technetium 9M DTPA is going to be a substance that is going to behave like an inulin, which means if it's going to behave like an inulin, what does that mean? What does it really mean if they behave like an inulin? Which means this is a substance that is going to get filtered, but no reabsorption, no secretion from the tubules, which means whatever substance that is coming out will be equal to the clearance. Which means if you want to know the extraction rate of DTPA, it's 20%. We saw already. That's why I told you there is something called extraction rate. 20% of the renal plasma flow will become GFR. So extraction rate of DTPA is approximately 20%. But nevertheless, this technetium 9M DTPA is one of the important surrogate nuclear markers of glomerular filtration rate. If you want to measure the glomerular filtration rate, you find out the DTPA scan. DTPA scan is very useful to accurately measure the GFR. Currently, we don't use inulin. Instead, we use either creatinine off-label, or if you want to measure more accurately, you can use the DTPA. All right. Saurabh is telling DMSA for scar. Actually, it's correct, but let us see how it will be useful for measuring the scar. So second area where DTPA can be used is for finding out urinary tract obstruction. Urinary obstruction. How can you find out urinary obstruction here? Second use. These are the uses of this particular tracer. So how you are going to measure urinary obstruction based on this tracer, because we know very well that this tracer, once it comes into the urine, once it comes into the tubule after glomerular filtration, it is neither reabsorbed nor secreted, which means it should directly flow into the urine. So if you are seeing the tracer in the kidney, but you are not able to see the tracer in the urine, means it's very simple that there is some sort of obstruction. That's why you're not able to see the tracer in the bladder and the urine, but you're able to see the tracer in the kidney. So that's why it's useful for assessing urinary obstruction, because it is not absorbed or not secreted. So that principle is also useful for measuring the urinary obstruction as well. But there is something called a split renal function or a differential renal function. Can anyone tell what do you mean by split renal function or a differential renal function? What do you mean by that? Many times we laugh at it, isn't it? Many times we laugh. Patients ask, sir, is it one kidney that is affected or both the kidneys that is affected? What will you tell if one kidney is affected or both kidneys are affected? Let us ask our students itself. If some patient is coming and asking, sir, I am having a high creatinine, whether my one kidney is affected or both kidneys are affected, what you will tell? What you will tell? Tell some answer. You will laugh most of the time. That's why you tell one or both, because we don't know. That's why. So that's what we refer to as split renal function or a differential renal function. These scans may be helpful in identifying the split renal function. That is the idea. These scans may be helpful in identifying the split renal function, which means you can see the kidneys depending on how much they are uptaking the traces and how much they are concentrating the traces. I can tell whether which kidney is having how much amount of function depending on a particular time with each tracer we have a particular point in time where you can look how much tracer it is accumulating. I can tell 80% function is managed by the right kidney and left kidney is managing only 20% function. So I can tell this kind of split renal function. With these traces, one important advantage that we have is we can find out the split renal function. That's the biggest advantage with these traces. Whether technetium 9M DTPA will be useful for assessing the split renal function or not? No, it's very poor in assessing the split renal function. What is the reason why it is not good in assessing the split renal function, even though it's able to measure the GFR properly? That is because its extraction is very, very poor, only 20% extraction, which means when you see the background, which means these traces are not going to be present only in the kidneys. This tracer is going to get injected into the blood, which means this tracer will be circulating in the blood. So when you see the background and when you compare the kidney, and this is the difference that we wanted to look for, and that's how we wanted to find where is the kidney and what is the kidney function. Suppose if the extraction is only 20%, which means the background will be so lit up and the kidneys will have only very mild uptake will be there in the tracer. So to find out which kidney is working or which kidney is not working with the background that is intense, and the tracer cannot be picked up that easily by the gamma counter because only 20% extraction by the kidneys are there. So we'll not be able to tell the split renal function because of its very poor extraction. And at the same time, the images will not be able to tell that whether what function the kidneys are having. So that's why this is not useful for assessing the split renal function. I think you'll be getting what I'm trying to tell. That's why we have another 2 scans. That's called a DMSA scan and a MAC3 scan. Let us go for this 99M MAC3. MAC3 is perfect most of the time because MAC3 is something that's going to behave like probably like your para-aminohippuric acid to some extent, we can tell, which means MAC3 is something that is going to get filtered, of course, first. At the same time, there will be a lot of secretion, too much of secretion that will be happening from the tubules as well. What are remaining is there, most of them will be getting secreted by technetium 99M MAC3. So that thing will be coming in the urine. So if you see, this is what we basically refer to as a kidney. I mean, the nephron is what we basically refer to as a kidney in the first place, the ultrastructural unit or a function unit of the kidney, which means this having a good amount of secretion, their extraction rate will be a little high. Extraction rate will be a little high, which means it will be approximately around 45%, which is much decent enough compared to that of the DTPA scans. So which means this can be used to assess the split renal function, which means the amount of tracer that is going to come into the kidney and the lumen of the kidney and lumen of the tubules is much higher compared to that of the DTPA. So that is the reason why this can be used to assess the split renal function. But most importantly, MAC3 is useful for one more important entity. What is that? Can you tell what is the MAC3's important function? Because it can assess the renal plasma flow, because it is behaving similar to that of heparin, even though not very accurate like that of para-aminohippuric acid, but it can very effectively tell the renal plasma flow because it's behaving similar to that of our para-aminohippuric acid only. So the next thing, what MAC3's advantage is, this is a very common question in exam. It can be used whenever renal function is reduced. When you want to do a scan, nuclear scan, in the element of a reduced renal function, your MAC3 is the way to go. MAC3 can be used in the setting of a reduced renal function. That's a very important point. Many times asked question names. And finally, we have another tracer that's called technetium 99M DMSA. This is going to behave very differently. I'll come back to that. But before that, what is an alternative? Alternative to MAC3 is the para-aminohippuric acid, pH, which can also tell you almost similar things what we have discussed. But since para-aminohippuric acid's extraction capacity is also very nice, 90% extraction. 90% extraction capacity for para-aminohippuric acid. You will think it's 100, but no, 90% because 10% of the blood supply goes to the capsule of the kidney. So not really 100% like what you think, but as a beginner, you can think 100% goes to the kidney, but no, 10% only goes to the capsule and 90% only goes to the kidney. So that's why we tell pH as the maximum extraction, 90% extraction. But because we cannot mix this with this kind of tracer, we cannot be able to pick up that signal from outside. So that is why para-aminohippuric acid is currently outdated, even though it has the best ability to find out the renal plasma flow. But we have a good one called I-123 heparin. Heparin is there. This is excellent. And in fact, this can tell the same thing as what your MAC3 does, which means this has 60% extraction, which is more than decent enough compared to that of MAC3. But still, this is not done because it's extremely costly. And you need a cyclotron to produce I-123. That's why commonly we don't use I-123. Instead, we prefer doing a technetium-based tracer. So MAC3, para-aminohippuric acid, and I-123 heparin, all these things are going to do the same thing. But commonly what we use is MAC3. And all of them can tell the split renal function and renal plasma flow. And MAC3 is typically commonly asked in exam. Common question asked in exam regarding MAC3 is the tracer that can be used in settings of reduced renal function, that is your MAC3. And technetium 99M DMSA, on the other hand, it has a different ability. This DMSA can enter the kidney by filtration, of course. And after entering the kidney by filtration, they bind to the tubules. They're not reabsorbed. Understand? It's not like reabsorption. They actually bind to the sulfhydryl groups in the tubules. They bind to the sulfhydryl groups in the tubules, which means they are retained. They are filtered and they are retained in the tubules. So that is the idea here. So amount that is coming into the urine is different. We are not talking about that. So which means if they don't come into the urine, you cannot really tell the renal plasma flow and all. Not possible, because they get bound to the sulfidal groups of the tubules, especially the proximal converter tubule. So again, it can be used to assess the split renal function, because the extraction capacity is very high here, because most of the tracer is tightly bound to the tubules, which means the kidneys extract a lot of tracer and keep it with themselves. So it could be good enough to assess the split renal function. But more importantly, where DMSA is used is because they bind to the tubules. If there is some tubular scar or tubular atrophy or tubular damage, so you will not be able to bind this tracer, and the kidneys will not be able to retain this tracer in the kidney. So that is why this DMSA is very, very useful for estimating the cortical scar or cortical infarct. All these things typically happen in the setting of a vesicoureteral reflex. So in exam, what they'll be asking you is, in the setting of a vesicoureteral reflex, if you want to perform a nuclear scan to tell which areas of the kidneys are scarred and which areas of the kidneys are not scarred, then you can think about a DMSA scan. And that's why many students tend to think about this DMSA as a scar scan. And many students used to think as a mnemonic also. This DMSA S stands for scar, because the DTP and MAC3 does not have S in it. That's why many students used to remember this DMSA as S stands for scar there to find out the kidney scar, especially in the setting of a vesicoureteral reflex. But nevertheless, the basic understanding is very important. But a DMSA is not useful for assessing the renal plasma flow. And second use of this DMSA scans is they can tell focal pyelonephritis, or it can tell cancer, whether it's an infection, focal pyelonephritis, versus it can tell whether it's a cancer, focal cancer in the kidney. Sometimes there is something called xanthogranulomatosis pyelonephritis, which can mimic a cancer, but in those settings, DMSA will again be useful. So these are the three uses of DMSA scan: split renal function, MAC3 and DMSA. DTPA cannot be used for split renal function. In fact, GFR use DTPA. MAC3 is more for renal plasma flow and split renal function, especially in the setting of low renal function, can be used. And DMSA mostly for identifying the scars, infarcts, pyelonephritis, and cancer. So these are the three nuclear scans, which are just a direct extrapolation of whatever we have learned here. So whatever the functions of clearance that we have learned here, the same things can be extrapolated to understand this three types of renography as well, nuclear scan. The next thing is to understand about one thing. There is something called captopril scan. You would have all heard about the captopril renal angiography. So, what does that mean? So there we will use the same DTP or MAC3, doesn't matter. Anyone you can use. Either, there is something called a captopril renal angiography. Captopril renal scintigraphy or captopril renal scan. So what we are going to do here is we are going to give something called a captopril. After giving captopril, we are going to assess the GFR. So post captopril, after 1 hour of giving captopril, so initially you give captopril, oral itself is enough. After giving this one, after 1 hour, you do a scan, either a DTPA or you can do a MAC3. So MAC3 can be used if there is a low renal function. DTPA can be used if there is good renal function, doesn't matter. But nevertheless, where you use this? What is the use of this scan? Very common question in exam, isn't it? Where will you use this? Anyone? I think there are so many people out there. Where will you use this captopril renal scan? 50 plus students are there. Where will you use? Yes, typically in the setting of a renovascular hypertension, especially renal artery stenosis. That's what we call renovascular hypertension. So using in this particular entity only, you're going to use a captopril renal scan. How it is helpful in renal artery stenosis? So that too, why you want to use captopril? That too, for that you need to understand what is glomerular filtration, what is GFR. That's why I asked you that scan, because everything can be interrelated, and most of the times whenever you're studying for postgraduate entrance examination, it's always better to correlate one thing and learn many things surrounding that. Suppose if you want to learn in order, it's very difficult. You will not be able to finish whatever is there. That's why I want to tell this. So because we need to know the findings of the ACE inhibitors and the ARBs on kidney. So this will be best time to assess this. So we know that there is a capillary here, and there's an afferent arteriole and an efferent arteriole. Remember, the afferent arteriole is predominantly under the control of PGI2 and angiotensin 2, and the efferent arteriole is predominantly under the control of angiotensin 2. So which means when you take angiotensin 2 alone, angiotensin 2 can produce efferent arteriolar vasoconstriction as well as afferent arteriolar vasoconstriction, afferent arteriolar vasoconstriction as well as efferent arteriolar vasoconstriction. But the effect of angiotensin 2 will be more on the efferent arteriole more than the afferent arteriole. That is the final take-home point. But nevertheless, remember, it can produce both afferent arteriolar as well as efferent arteriolar vasoconstriction. So why you have this principle in the first place behind us? So that is because we need to know something called, what do you mean by renal autoregulation? Because kidneys can autoregulate their blood flow with a varying blood pressure of between 80 to 180 millimeters of mercury. At this range, there will be effective autoregulation. This is the autoregulated range of the kidney. At MAP of 80 to 180 millimeters of mercury, in the kidney, the blood flow will be relatively constant. And because the blood flow is relatively constant, GFR also will remain relatively constant. Beyond this or less than this, there might be difference, but 80 to 180 range is the autoregulated range of the kidneys. And the reason for autoregulation is the angiotensin, one of the main reasons for autoregulation. That's why when you give ACE inhibitors, there might be a defective autoregulation in certain individuals. Let us come back to that. So first, we need to know the size of the afferent arteriole and the size of the efferent arteriole, and what is the effect on the GFR. What is the effect on the GFR? Let us assume normal. Normal means it will be a normal GFR to start with. Whenever there is a decrease in afferent arteriolar size, with no change in the efferent arteriole, the GFR will drop because you are producing reduced renal perfusion. That's the idea here. And when you increase the afferent arteriolar size, afferent arterial diameter, and if you keep the efferent arteriolar constant, your GFR might increase. And when you decrease the afferent arteriolar diameter and increase the efferent arteriolar diameter, the GFR will surely drop to a great extent because you are reducing the intraglomerular pressure. And because when you write GFR, it will be equal to intraglomerular pressure. More the IGP, more will be the GFR. So you can tell the intraglomerular pressure also simultaneously. Because IGP is reducing, your GFR will definitely reduce in this setting. So when the afferent arteriolar size is, when the efferent arterial size is increasing and the afferent arterial size is kept constant, in this particular situation, your GFR might be normal, or even it can be decreased depending on the effect of how much the efferent arterial is dilated. If the efferent arterial size is decreased, and if you are keeping the afferent arterial size normal, then in this situation, the GFR might be normal or it might be increased. If you keep the, if you decrease the, increase the efferent arterial size, and if you decrease the afferent arterial size, the GFR will surely increase in this particular situation. So these are the things that you need to know. Here it can be normal depending on that. So these are the situations that you need to know. But more importantly, what situation that you will get in the setting of autoregulation is this kind of very complicated scenarios where the size of the efferent arteriole may be less, but the size of the afferent arteriole may be a little high. So thereby you need to preserve the GFR. So that is the idea here. So these principles are very important to understand the basic stuff. So then we'll move on to how the ACE inhibitors are going to act and how the ARBs are going to work on the kidneys in the first place. So first, you have to be very careful and grasp this understanding first. So what happens if you give ACE inhibitors to a patient who's having normal blood pressure or probably hypertension, or those who don't have any problem in the renal autoregulation or don't have any problem in the perfusion? So a normal patient, or if a patient who is hypertensive and you are giving ACE inhibitors or ARBs to them. So here the renal perfusion is normal because these patients are deemed normal. Here the renal perfusion is absolutely normal. There's no problem in the renal perfusion, completely normal. And you're giving ACE inhibitors and ARBs to them. Nothing will happen much because the kidneys can auto-regulate their blood flow. Because it's not only the ACE inhibitor, AT2 and prostaglandin I2 that is important for autoregulation. There is also something called a myogenic response that you have studied in physiology. And that is important for autoregulation, which you're not going to discuss. Suppose many students think that if you are blocking the angiotensin 2 here, you're going to increase the efferent arterial diameter. Now, if you increase the efferent arterial diameter, you're going to change the GFR dramatically. No, that does not happen. Why it does not happen? Because here, because the renal perfusion is normal and the patient is having, this thing, non-normal auto-regulation. So now the auto-regulation will come into play and they will not allow any much changes in the GFR. So they make sure that the GFR remains almost normal. There won't be any much change in the GFR. That's what happens in the setting of a normal or a hypertensive patient. Suppose if you are giving this to a RAS patient, suppose if the patient is having a renal artery stenosis in this setting, and in that particular patient you are giving a ACE inhibitor or a angiotensin receptor blocker. What will happen in that setting? Already these patients are having reduced renal perfusion. Because the reduced renal perfusion, already autoregulation will not be there properly. Because autoregulation is defective in these individuals, now their entire GFR will be maintained by the angiotensin II prostaglandin mechanism only. So whenever the perfusion is low, so why your renin-angiotensin system is getting stimulated? Because whenever perfusion is low, you get RAS activation. When you get renin activation, you will result in development of angiotensin II. This angiotensin II is the one that produces vasoconstriction. Please understand, it produces both afferent as well as efferent arterial vasoconstriction, but differentially it produces more efferent arterial vasoconstriction compared to afferent arterial vasoconstriction. Thereby it maintains the GFR in the normal range and perfusion pressure in the normal range. That is the idea. So that's how they maintain the GFR. Now the GFR will be maintained. This is one way of maintaining the GFR. So in a patient who's already having a low renal perfusion, the autoregulation will already be defective, which means I told you it will happen only at this range, 80 to 180 millimeters of mercury of mean arterial pressure. If suppose because of severe stenosis, the perfusion pressure is so low, in that setting, your autoregulation will be defective and their entire perfusion will be based only on the angiotensin II related system. And that is the one that is constricting, dilating, and that's the one that is actually maintaining the GFR. Now, if you give an ACE inhibitor and the ARB, angiotensin receptor blocker, and now the angiotensin II's effect on the kidney is also taken off. Now the kidney will be solely dependent on the renal perfusion, which is already low, and they will suffer from a dramatic decrease in the GFR. This is what is going to happen in a patient who is having a renal artery stenosis. That is what we are going to use in our captopril study. Suppose the patient is having a unilateral RAS on one side. If the patient is having a RAS, now after giving a captopril, when you give a captopril, what's going to happen is your area, for example, the side of renal artery stenosis will suffer from a dramatic fall in the GFR because that side autoregulation will be completely lost. On the other side with normal kidney, normal vasculature, on the other side, there will be a well-preserved GFR because that's a normal side. There's no problem. Because as I told you, in a patient who's having, patient who's normal or having a hypertension, benign hypertension, essential hypertension, not renal vascular hypertension, autoregulation will be intact, which tends to maintain the GFR in the normal range. So now the side which goes for, which has renal artery stenosis will have a dramatic drop in the GFR, and the side with normal kidney function, no renal artery stenosis, will have a preserved GFR, so that difference will be augmented. So, even without this captopril, you can find out the perfusion using the DTPA scans or MAC3 scans. But after giving captopril, your difference will be augmented so much so that one side there will be a dramatic tracer uptake, other side there will be a dramatic loss of tracer uptake, so that you can see this difference and you can tell that the side which is having low GFR is the side that is having a renal artery stenosis. And that is why the mechanism of autoregulation is very important, and that is why you need to understand the problem in the bilateral RAS as well. Suppose, let me assume if you are giving can you give ACE inhibitors to a patient with unilateral RAS? My question is yes or no. Question is yes or no. Can you give ACE inhibitors or ARBs to a patient who's having unilateral RAS? You're going to answer yes or no. Yes or no? Of course, yes. Of course, yes. That's pretty good, to be honest. You have to give ACE inhibitors to patients who are having unilateral RAS. Why you can give in unilateral RAS? Because it's actually okay to give ACE inhibitors in a patient with unilateral RAS, because ACE inhibitors have a lot of anti-atherogenic properties, because most of the times your renal artery stenosis will be due to atherosclerosis only. And you can see that in a sense, if you see, ACE inhibitors reduce the perfusion to the affected kidney, and they are actually pushing the blood, maybe diverting the blood to the normal kidney. So it's good actually. I mean, what we need is a normal renal function. We don't want blood to be going to the affected kidney. So in the side which is normal, blood will be diverted. So that's basically good. So in a unilateral RAS, in fact, giving ACE inhibitors becomes advantageous. But whereas in a patient who's having a bilateral renal artery stenosis, this becomes completely problematic, because after giving ACE inhibitor or an angiotensin receptor blocker, now there will be a complete loss of autoregulation, and already they'll be having defective autoregulation. Now angiotensin 2 is the only thing that is maintaining the perfusion and the GFR in the kidney, and the intraglomerular pressure is maintained only by the angiotensin 2. There's nothing else that is maintaining in a patient who's having a bilateral RAS. Now if you're going to give an ACE inhibitor on ARB, there'll be a complete loss of all this perfusion maintaining intraglomerular pressure GFR, and there will be a dramatic drop in the GFR, and this will result in sudden rise in the serum creatinine. So whenever in exam giving an ACE inhibitor causes rise in serum creatinine within a few days or few weeks, always think about a bilateral renal artery stenosis. That's the only diagnosis that you have to make. That's why ACE inhibitors and ARBs are contraindicated in a bilateral RAS. But how will you know that the patient is having a bilateral RAS or not? I mean, pharmacology books will tell bilateral RAS is contraindicated. But when the patient comes to you for the first time with hypertension, you don't know whether the patient is having RAS or not. So this is how I'm going to find out. So after giving ACE inhibitors and ARBs, if there is a dramatic rise in the serum creatinine, and I know that this patient is suffering from a bilateral RAS, then I will start evaluating for a bilateral RAS. What is the cutoff for GFR drop? So if the GFR drop is 30% decrease from the baseline, or if there is 25%, I'm telling reverse. Okay, the GFR drop is 25% from the baseline, or if there is 30% increase in the serum creatinine from the baseline. So in this setting, I can tell a dramatic rise in serum creatinine or a dramatic drop in the GFR. So both these will tell you strongly that the patient is suffering from a bilateral RAS. In that setting, I have to evaluate for a RAS. At the same time, I should stop ACE inhibitors and ARBs irrespective of the scenario. Fine, all right. Now, suppose you might be asking one more situation where patient who is having hypertension, let us assume, having a benign arteriosclerosis, and can you give ACE inhibitors in this patient, ACE inhibitors and ARBs? And you don't know, this benign arteriosclerosis is the, pathological diagnosis. You cannot know whether the patient is having benign arteriosclerosis or not. Can you give ACE inhibitors or not? Yes, you can give. And most of the time, if you have a benign arteriosclerosis, patients will be having proteinuria. So how hypertension causes proteinuria? Very simple. A direct evidence, because hypertension produces increased perfusion, increased BP is there. This increased perfusion will dramatically raise the intraglomerular pressure. Long-standing increase in intraglomerular pressure will result in hyperfiltration. And this long-standing hyperfiltration will result in damage to the pores. These are delicate pores that we have. These are like sieve-like pores that we have in the foot process of the podocytes. And they will be damaged because of long-standing high pressure and high intraglomerular pressure. And the patient will start leaking the proteins. And you will get proteinuria in this situation. So to prevent that only, I will tell this benign arteriosclerosis basically a protective mechanism. So what they do is, what do you mean by benign arteriosclerosis? You'll have this kind of vessels and they'll go for this thickening. Why they go for this kind of thickening? This is a reactive change. You would have studied in pathology. Why they go for reactive change? Because they have to actually reduce the perfusion pressure. They have to reduce the perfusion pressure. And that is the reason why basically these patients are having this kind of benign arteriosclerosis. So basically the idea here is to reduce the perfusion pressure. Only when you reduce the perfusion pressure, you can prevent the further damage to the kidneys. That's why they go for reactive benign arteriosclerosis. That's called a hyaline arteriosclerosis. You would have studied in pathology. So giving ACE inhibitors and ARBs are beneficial in this situation. Why? Because they reduce the intraglomerular pressure. How they reduce the intraglomerular pressure? Because whenever the patient goes for this kind of benign arteriosclerosis, which means the vessels are thickened, now the differential action will be lost. Whether the vasoconstriction will happen in afferent arteriole or efferent arteriole, which will be predominant. This kind of things will not be taking place properly. And usually uniformly, they will reduce the afferent arterial diameter as well as the efferent arterial diameter when you give angiotensin 2 inhibitors. For example, I told you angiotensin 2, we take this the efferent arterial and we take this is the afferent arterial. You know that angiotensin 2 is going to act on both, but you would have studied that preferentially they act on both. I mean, on efferent arterial more than that of the afferent arterial. But whenever they go for this kind of benign arteriosclerosis, this difference will not be there because the vessels are already thickened to a great extent. So once they have been thickened to a great extent in both this afferent arterial as well as efferent arterial, they will have almost equal amount of action. So which means they are going to produce vasoconstriction of afferent arterial as well as vasoconstriction of efferent arterial, almost in equal proportions because the vessel is thickened now and there is no preferential action like this anymore because of benign arteriosclerosis. And in this situation, reducing the afferent arterial diameter is going to reduce the perfusion pressure. And this reduction of perfusion pressure will definitely reduce the intraglomerular pressure. And this reduction of intraglomerular pressure is actually quite beneficial in the setting of benign arteriosclerosis, because the main problem in hypertension is this continuous rise in intraglomerular pressure causing proteinuria. That's why hypertensive proteinuria can be effectively reduced by reducing the intraglomerular pressure, so that your proteinuria will reduce after giving ACE inhibitors or angiotensin receptor blockers. That is by reducing the perfusion pressure and by reducing IGP, which is actually beneficial in this setting. Only in bilateral RAS, this becomes harmful. But in unilateral RAS, or probably even in the setting of a benign arteriosclerosis, this basically becomes beneficial. That's why. On the other hand, whenever the patient is having diabetes mellitus, what happens in the setting of a diabetes mellitus? So now, if you take a glomerulus and diabetes mellitus, even though all this have to be explained a little slowly, but I don't have time now. So if you see a glomerulus, you know that efferent arterial thickening will happen preferentially in diabetes mellitus, because now the efferent arterial diameter is reduced and afferent arterial diameter is not changing that much. You see now the perfusion pressure will again increase. Because of that, intraglomerular pressure will increase. Because of that, the filtration will increase and the patient will go for hyperfiltration once again. Because the patient goes for hyperfiltration, these delicate pores that are there once again will be damaged, and they will result in proteinuria. Here it is not arteriosclerosis. Here it's only TBM. The thickening here is not due to arteriosclerosis. Here the thickening is due to thickened base membrane in the efferent arteriole. Now, again, because of this differential action, now if you give an ACE inhibitor or an angiotensin receptor blocker in this particular patient, now you know they are going to act on both afferent arteriolar area as well as in the efferent arteriole. The efferent arteriole is thickened, so the effect on the efferent arteriole may not be that great, but they're going to produce afferent arteriolar vasoconstriction, and they're going to reduce the perfusion pressure. And they're going to reduce the perfusion pressure. Once they reduce the perfusion pressure, they're going to reduce the intraglomerular pressure. And once you reduce the intraglomerular pressure, they're going to result in reduced proteinuria. So you can see that in the setting of proteinuria, especially this ACE inhibitors become highly beneficial, irrespective of the cause. It could be hypertension, it could be diabetes, doesn't matter. The main reason, there are two take-home points here. The main reason for proteinuria is increased intraglomerular pressure. This high IGP is the main reason for development of proteinuria. And ACE inhibitors, especially in pathological states, are able to reduce the proteinuria by dramatically reducing the intraglomerular pressure. Either they can vasodilate the efferent artery and reduce the intraglomerular pressure, or in an affected kidney where there is a thickened base membrane or hyaline arteriosclerosis, you are going to result in a reduced intraglomerular pressure because of preferential action on the afferent arteriole. So this kind of differential action of ACE inhibitors on angiotensin 2 and efferent arteriole and afferent arteriole is very important in actually preventing the proteinuria, and that's why they are actually beneficial in the patients who are actually suffering from proteinuria, maybe due to hypertension or maybe due to diabetes. But even in CKD you can use. How you can understand in CKD? Because in CKD there is something called a progression of CKD. So how this progression of CKD happens? Very simple. For example, you have 1 million nephrons in each kidney. So let us understand this very simple way. So your filtration pressure will be proportional to the constant called as filtration constant. That is actually basically something equal to the surface area. So this is a very important derivation that you need to know, which means whatever may be the filtration fraction, that is actually proportional to the surface area of the kidney, which means the surface area of the kidney is reduced means your filtration fraction is going to reduce, the GFR is going to reduce. Basically, that's the most important idea. So now I can tell, I mean, in an easy way, if you want to tell, you have 1 million nephrons, or let me tell in an even more simple way, you have 10 nephrons doing a particular function and producing a glomerular filtration, particular amount of GFR. Now let us assume due to some damage, maybe diabetes or maybe ADPKD or some disease is there, where you lose some nephrons, and maybe due to some AK, toxin, some drug you have taken that has damaged the nephrons. Now you end up with only 6 nephrons. And now you know 6 nephrons, to maintain the GFR, it needs a huge pressure. It's like 10 people lifting a weight, and now only 6 people are there, they have to lift the entire weight. So they will try to maintain the GFR in the normal range. So to maintain the GFR, the autoregulation process will screw up the kidney and screw up this remaining 6 nephrons. And they can do that by only increasing the intraglomerular pressure and increasing the filtration. Only by increasing filtration and by increasing the intraglomerular pressure, by their autoregulation, they can maintain the GFR in the normal range. Otherwise, they cannot maintain the GFR in the normal range. They will struggle, they will work hard to maintain GFR in the normal range, but they may be possible in the initial stages, but once the nephrons become, for example, only 3 nephrons now, because as the nephrons becoming increasingly overloaded with work, so more and more nephrons will go for death and apoptosis, and only 3 nephrons will work. And of course, they will not be able to maintain the GFR, but they will try to maintain the GFR, and they cannot maintain the GFR, and they're going to produce high amount of filtration, pressures and intraglomerular pressures, and they're going to keep on dying over a period of time until you end up with a end-stage renal disease. And this is what we refer to as something called a progression of CKD. And one of the main reasons, there are many reasons for progression of CKD. It's not only the increased filtration pressure that is going to result in progression of CKD. One of the main reasons is the progressive hyperfiltration that is happening over a period of time. So 10 nephron to 6, 6 to 3, 6 to 0, where you'll end up with an end-stage renal disease completely. So this progression, one of the main things that affect this progression of CKD is the hyperfiltration. So you have to see in a relative term once again, hyperfiltration means not entire kidney is going for hyperfiltration, because these nephrons have already died and the remaining nephrons are going for hyperfiltration. So over a period of time, the remaining very little nephrons are going for hyperfiltration, and over time they are going to die. And one of the important evidence of hyperfiltration in clinical practice is the proteinuria that you see. So if you have proteinuria, definitely there is some hyperfiltration going on. That is why the slits are damaged. That is why you are resulting in a development of proteinuria. That's a direct evidence. We know that. So that is why even in this setting, to reduce this hyperfiltration and to relax these nephrons and to prevent the overloading and to reduce the burden, you can give ACE inhibitors and angiotensin receptor blockers. That's another way. So point number 4, ACE inhibitors and ARBs are actually beneficial in patients with CKD to prevent the progression of CKD, especially in those patients who are having proteinuria. If the patient is having proteinuria and having CKD, means definitely there is some progression of CKD that is happening due to the hyperfiltration itself. That's evidence is there in the form of proteinuria, so you can give ACE inhibitors. If there is no proteinuria, means the progression of CKD is actually happening because of the background disease itself, maybe due to diabetes or maybe due to hypertension or some reason. If without proteinuria, if it's happening, then it must be due to the background disease itself. For that, we'll use some other strategy. But if there is a proteinuria, one additional strategy that you can follow is giving ACE inhibitors, because you can prevent the progression of CKD, which means ACE inhibitors are the gold standard. So in your practice, ACE inhibitors are very, very important. ACE inhibitors are beneficial in patients with hypertension, especially if they're having proteinuria. They're extremely beneficial in patients with CKD, especially if they have proteinuria. They're extremely beneficial because in this setting, they reduce the progression of CKD. In patients who are having diabetic kidney disease, of course, diabetes is manifested by this hyperfiltration proteinuria only. So you can use ACE inhibitors where it will be extremely beneficial. And even in unilateral RAS, they are going to be extremely beneficial. Even in any other condition that produces ASCVD, atherosclerotic cardiovascular disease, it could be a stroke or it could be a TIA, because ACE inhibitors are considered to be strongly anti-atherogenic, because angiotensin 2 is something that is considered to be strongly atherogenic, whereas giving an ACE inhibitor or angiotensin receptor blocker can behave as anti-atherogenic agent. So in any ASCVD, you can give as a add-on agent, like maybe a chronic stable angina, maybe a MI, or maybe a stroke, maybe a TIA. ACE inhibitors can be used. They are absolutely beneficial and they can reduce the mortality in those settings. So these are the primary areas where we're going to use ACE inhibitors in reality. But you know the side effects of ACE inhibitors. Cough is going to be very important, and it's typically bradykinin related cough. We know that. And that's why it will not be responding to your basic antihistaminics. You should stop. And this cough is more with ACE inhibitors compared to that of angiotensin receptor blockers, considerably higher with ACE inhibitors. And of course, you know, you can result in the development of, reduced renal function, hyperkalemia, second important entity, because ACE inhibitors can prevent the conversion to angiotensin 2, or angiotensin receptor blockers can prevent the action of angiotensin 2 on the zona glomerulus of the adrenal gland. So hyperkalemia is a very important side effect. These are two important side effects I need to know. But if they ask you the contraindications for ACE inhibitors, first contraindication you can tell for ACE inhibitors is the hyperkalemia. You should never give, especially if the starting serum potassium is more than 5, I never give ACE inhibitors because that's a high risk patient. But for stopping ACE inhibitors, 5.5 is the cutoff. I think I've told you this in cardiology itself. For starting, if it's more than 5, I don't give. For stopping ACE inhibitors, like maybe I can keep a cutoff of 5.5. Beyond 5.5, I can stop if the patient is already taking. But to start more than 5, it's a contraindication. You cannot start. Any hypoperfusion states, you should not give. Because in hypoperfusion, for example, the patient is having diarrhea. And because of that, he's having hypotension and shock. Already the MAP is low and they cannot do autoregulation. The only way they're maintaining the GFR is your angiotensin 2 mechanism only. That's very important in the kind of hypoperfusion and shock. So now when you're giving ACE inhibitors in a patient who's having a diarrhea, volume loss and shock, and this hypoperfusion, the angiotensin 2 is the one that is correcting that hypoperfusion inside the kidney, and you remove that effect also, and the patient will go for a dramatic drop in the GFR and they'll go for serious renal failure. So you should never give that in hypoperfusion states. Any shock patients, any hypovolemic patients, if you think the patient is having hypoperfusion, it's better to avoid ACE inhibitors as much as possible. And third contraindication is the bilateral RAS. We know that, bilateral renal artery stenosis. And even I told you how to analyze that bilateral renal artery stenosis in reality, because in reality, nobody will come with a certificate of bilateral renal artery stenosis. So when you start ACE inhibitors, if the GFR drops by a particular value, or if the serum creatinine rises by 25%, or the GFR drops by 30%, as we saw already, our GFR drops by 25%, or the serum creatinine rises by 30%. In this situation, you can stop. Think it's a bilateral RAS by default, and you can start evaluating for RAS. At the same time, it becomes a contraindication for giving any further ACE inhibitor for that matters. So these are the important side effects and contraindications, and you have to very clearly know whenever there is a proteinuria, irrespective of the disease, you can actually use ACE inhibitors or angiotensin receptor blockers. Routine investigation after starting ACE inhibitors. Only my renal function I will be doing. The only thing I need is the potassium and the creatinine. These are the two things that is very, very important after starting ACE inhibitors. Apart from that, I don't think any other investigation will be helpful, or ARBs. So actually we start with captopril renal scan, but I told you about the physiology of afferent arteriole and efferent arteriole. Then I showed you why ACE inhibitors can be given unilateral RAS, how captopril scan is useful, and why it is contraindicated in bilateral RAS. And we have learned something about renal autoregulation also, and how it's effective in proteinuria, and how it's effective in reducing the progression of CKD. So we know all these things. So that's why, I want to tell a lot of these things in the simple background basic physiology itself. Even though it looks a little tough, because if you understand the basic renal autoregulation and what conditions, what you need, then it becomes relatively simpler. Remember, under normal states, your myogenic response itself is more than enough, where your angiotensin 2's effect on kidney will be very negligible. But when you go for hypoperfusion states, your angiotensin 2 becomes really, really important. So that is the reason why angiotensin 2 blockers or ACE inhibitors are going to be more badasses in hypoperfusion states. But in a normal perfusion states, or if the patient is having problems due to increased intraglomerular pressure, ACE inhibitors are excellently beneficial. So in that setting, you can give. One of the important examples of hyperfiltration is proteinuria. So that's why ACE inhibitors, by reducing the filtration pressure and reducing the intraglomerular pressure, they can reduce proteinuria to a certain extent. So that's why they are beneficial. So ACE inhibitors can be used to reduce the progression of CKD. Many students don't confuse that serum creatinine, if it's high, it's a contraindication. I don't know. Many students do ask that question. Remember, ACE inhibitors can be given in patients with CKD itself. So why you really tell that serum creatinine is a contraindication? Serum creatinine is never a contraindication for ACE inhibitors. Unless and until there are other contraindications like hyperkalemia is there, serum creatinine alone does not become a contraindication for ACE inhibitors. It's the context of raised serum creatinine that becomes a contraindication. Like for example, if the patient is having raised serum creatinine due to bilateral RAS, it becomes a contraindication. The patient is having raised serum creatinine due to diarrhea or a shock, that becomes a contraindication. That's the most important point there. Context is very important. In which context the high serum creatinine matters. Is it clear whatever I told till now? Or you have any doubts? Fine. So everyone has answered. Okay, good. So you have understood whatever I told, then that's fine. So the most important final take-home point is the captopril renal scan. That is useful for renal artery stenosis identification. And second is the ACE inhibitors importance in hypoperfusion and non-hypoperfusion states, and its importance in proteinuria and CKD. So this is going to be the most important. Okay. Okay. Sanju is telling started from plain rice and ended in biryani. Okay. No, thing is, no, it's all about time. I don't really get sufficient amount of time to explain a lot of things. It's actually, things look a little complicated, but they are basically quite simple. They are not that complicated like what we think. It's all about our understanding. Okay. Now, next step is to understand the importance of probably serum creatinine we can talk about. And the urinalysis. Okay. What are the problems with serum creatinine? And we talked about some important traces, nuclear traces that is useful for GFR. But what about the serum creatinine? Serum creatinine as a whole. We know serum creatinine is basically coming from the muscle, number one. So which means muscle strength, or probably the volume of the muscle is really important. If the patient is cachexic, then your serum creatinine may be a little low. If the patient is having a huge muscle like Arnold Schwarzenegger, the serum creatinine may be a little high. So the first thing that alters the serum creatinine is the muscle. So that's one pitfall of the serum creatinine. Second thing, creatinine always has a lag. There's something called creatinine lag is there. So which means very clearly, for example, if there is a kidney insult that is happening at this point, and if you take this is the serum creatinine to start with, so serum creatinine will usually take some time before it starts rising, which means there is a definitive lag you can see. It takes some time to rise. It doesn't happen immediately. So this is sort of a lag. In general, this creatinine lag is somewhere around 6 to 48 hours, which means immediately not rise. It will take around 6 to 48 hours till it starts rising. So this lag is something something that we don't want really in our practice, because we wanted a marker that we need to identify the kidney insult as soon as it has happened. So that's why creatinine is not a very good marker. But nevertheless, like we have huge experience on creatinine. That's why we are still relying on creatinine. Cool. So this creatinine lag is very important. The second problem is the lag. That's why we have some modern markers which will tell as soon as the insult happens, within a short period of time, they start rising. That's why we wanted these novel markers. There are novel markers which can do that, where the lag is going to be extremely less, which means it can happen as soon as the insult has happened to the kidney. Number one. Third problem with the creatinine is the fact that it does not correlate to the GFR. In the sense, like, first it overestimates GFR. Number one. We are talking about creatinine clearance. We saw that time itself. It overestimates GFR. It is more than that of the GFR. Second point is the fact that if you see the creatinine and the GFR curve, the second curve I'm going to talk about, the creatinine and the GFR curve, I can write the serum creatinine here. And if we take the eGFR curve, if you see, they are not actually linear. If you see this something like that, it's not basically linear in this thing. So mostly it is like sort of a sigmoid kind of a nature, where you can see that linear means when I'm talking about it should be like this. the more the creatinine is, lesser should be the GFR. It's not like that basically. It has some sort of this kind of relationship. For example, if you take in the initial areas, for example, at a creatinine of 1, let us assume, this is an approximate graph only. Let me assume the GFR is maybe 90 or 100. So let me talk about that. Now, if you take a creatinine of 2, see the drop in the GFR. It's basically a dramatic drop in the GFR is there. Now the GFR is only maybe 50 or 40 in that setting. I'm just telling approximately. It depends on a lot of other entities as well. Suppose if you have a GFR of 4, creatinine of 4 maybe, you can see the GFR is only maybe 20 in this setting. But if you take a creatinine of 5, GFR will be just 15 or 14, which means you see the drop from 90 to 50 when the creatinine becomes 1 to 2. On the other hand, if you have a creatinine increase from 4 to 5, the GFR drop is not that dramatic. Like it's only 20 to 15, which means as you go towards the higher and higher creatinine, the creatinine really does not matter much. Only in the lower areas of creatinine, only in the lower zones of creatinine, the actual creatinine values matter a lot. But as the creatinine moves high and high and high at 3, 4, 5, the creatinine really does not matter that much because the GFR is not going to change that much. So that is why in acute kidney injury, when you talk about an acute kidney injury, I'm a normal patient, I'm getting a new kidney injury, my serum creatinine becomes a lot of importance because my rise from 1 to 2 is more important than my rise from 6 to 7. Suppose if we take a CKD patient, my serum creatinine is not important because already they are having 2, 3, already high creatinine. So in that minor fluctuation creatinine from 2.7 to 3 or 3 to 4, I don't really think that is important. In that context, my GFR is going to be the most important, eGFR. That is why any AKE staging, if you take, any acute kidney injury staging you take, it will be basically based on the serum creatinine. There will be not much with regards to the GFR. On the other hand, if you take any CKD staging, the main thing in the CKD staging itself will be the eGFR only. So eGFR calculations are very important from the CKD perspective. As far as the AKA perspective, the serum creatinine becomes very important because sudden changes in creatinine are more harmful than that long-term stable changes in creatinine that is happening in the setting of a CKD. So that doesn't give any much importance. So that's why you need to know that one important final point to tell is that GFR is actually not having a linear relationship with that of the serum creatinine. It's going to have a kind of a weird relationship. It doesn't have a linear relationship. At higher creatinine, it doesn't really matter. At lower creatinine, creatinine matters, but at a higher creatinine, creatinine really does not matter that much. Okay, but still, if they ask you how to measure GFR, suppose if you want to measure eGFR, you need to adjust a lot of things. So that is why there are some formulas that try to avoid these pitfalls due to creatinine and adjust a lot of things and give a eGFR using a serum creatinine. So it is still not very accurate, but still you can use certain formulas. For example, the first formula that used serum creatinine to measure GFR is the Cockcroft-Gault equation. Cockcroft and Gault equation, which use the serum creatinine to measure the GFR. So what do you mean by the Cockcroft-Gault equation and how you measure your eGFR based on the Cockcroft-Gault equation? So this one formula that you definitely need to know for the exams because they're going to ask for sure. So the Cockcroft-Gault equation tells 140 minus age multiplied by body weight in kilogram divided by 72 multiplied by serum creatinine. So this is the Cockcroft-Gault equation, and 0.85 can be multiplied if the person is a female. If it's a female gender, then you can additionally give a correction of 0.85 multiplication. If that is not the case, male means you don't want that 0.85 correction factor. So let me give you a simple one so that you will be able to get a grasp of it. So let me tell a 40-year-old man who's having 70 kilogram of body weight, and a serum creatinine of 1 milligrams per deciliter. So what is the GFR in this particular patient according to Cockcroft-Gault equation? Usually your exam questions will be so simple like this. Mostly, it's a very simple one. So you can do a mind calculation itself. I don't think you need any complicated calculations in there. What is the GFR according to the Cockcroft-Gault equation? In this example, come on. What is the GFR? Yes, it's 100. 140 minus 40 multiplied by 72 is the body weight divided by 72 multiplied by 1. So males don't correction factor. So 72 gone. 100 minus 140 is 100. So here the GFR is 100. Simple calculation. So all you need to know is the formula in exams. That's all. This Cockcroft-Gault equation. On the other hand, we have other equations, like for example, MDRD equation is also there. Then we have the CKD EPA equation as well. MDRD stands for modified diet in renal disease. And usually you won't get any MDRD and all because it is a calculator based thing. Even we do in practice using calculators only. And we have CKD EPA, that is chronic kidney disease epidemiological index. That's called CKD EPA. But as far as Indians are concerned, most of the Indian nephrologists, if you ask, they will use the CKD EPA calculation only. They will not be using the MDRD equation in India usually, because that is more for Asians and blacks. That's why. One important difference to notice, this MDRD and CKD EPA equation gives the eGFR in mLs per minute per 1.73 meter square body surface area. So directly they give this value. But the problem with Cockcroft-Gault equations, Cockcroft-Gault equation will tell only the GFR in ml per minute. But basically you need to calculate it for your body surface area, which means it's not giving for that 1.73 meter square body surface area. So you have to multiply that and you have to adjust that for the body surface area. Usually the standard way of, projecting the GFR is by mLs per minute per 1.73 meter square body surface area only. Based on this only the CKD staging will be there. So, but Cockcroft-Gault's biggest problem is they will tell only in ml per minute, but they will not give that creatinine clearance eGFR per body surface, 1.73 meter square body surface area. So you should do that additional calculation also. So that's why we don't use either one of these things will be used in the modern practice. In that in India, usually they prefer using a CKD EPA calculation. That's what we use. And all these things are telling that we definitely need a novel mark. At the same time, creatinine will not tell the site. So which side the damage is happening, you can't really tell where is the problem, or it cannot tell you the process. Like I told you, your DTPA scans can tell you the GFR as well as whether there is any obstructive uropathy, but creatinine will be the same irrespective of a pre-renal AK or a post-renal AK or a intrinsic renal AK, doesn't matter, creatinine will rise. So creatinine will not tell the type of injury. At the same time, creatinine cannot tell the site of injury. For example, creatinine, we know it's filtered, it's secreted, and it's finally coming into the urine. So if you have an obstructive uropathy, creatinine will rise because creatinine cannot go out. In intrinsic renal failure, creatinine will rise. In glomerular injury, creatinine will rise. Even if there is a low perfusion to the kidney, creatinine will rise. So creatinine cannot tell you the type of AK or probably even the site of kidney injury. You cannot assume with the help of creatinine. That's why we are in search of many modern markers. So among all the modern markers, the most important, so the next thing what they'll be asking you is what are the modern or the novel markers of AK, of kidney injury. So a modern marker should be in such a way that should be able to tell the site of injury or probably at least the type of injury. And at the same time, a novel marker should be able to rise immediately as soon as possible, and it should not have any problem with that of muscle or sort of thing, because creatinine is biased by the muscle. More the muscle is, more can be the creatinine. For example, in a cachexic lady who is a cancer patient, even creatinine of 1 may be considered as an acute kidney injury. In Arnold Schwarzenegger, even creatinine of 1.2, I will not take it as an acute kidney injury because his muscle is that big. So in that particular guy, like a creatinine is supposed to be a little higher only. So creatinine is actually some problems in the muscle mass as well that can be biased easily. So what are the modern markers of AK? Modern markers of AK, one of the important markers is going to be the cystatin C. That's going to be an exam question as well. Majority of the current nephrology journals, everything is based on cystatin C only. And of course, if you want to do a research and you want to publish an international journal, your eGFR measurement should be based on cystatin C assessment only. So what is cystatin C basically? Cystatin C is something that is produced by all nucleated cells, which means it's an endogenous marker. Remember, one of the important thing to notice, the marker of AK should be an endogenous marker. There's no point in using an exogenous marker like inulinol. So that's why we need an endogenous marker to predict AK. So all nucleated cells will produce this cystatin C. And if we take a nephron, and if you see how cystatin C behaves a little different in the perspective that cystatin C is getting filtered and cystatin C will not be reabsorbed. In the sense, cystatin C will be taken up by this tubular cells. especially by the PCT, cystatin C can be taken by the tubular cells, and inside the cells itself, they'll be destroyed. I mean, why I'm telling you this? Because when it's reabsorbed means you'll be confusing with urea. Urea, remember, it is reabsorbed back into your blood. But yes, cystatin C is not released back into the blood. It is basically destroyed within the cells itself, and less than 1% of the cystatin C is coming in the urine. Cystatin C has a lot of advantage. For example, if your serum cystatin C is increasing, usually that will be a marker of your glomerular injury, which means it can tell, to an extent, it can tell the site of injury also. Usually it will be a glomerular injury. Suppose if your urinary cystatin C is increasing, which means now the tubular damage is there. That's why whatever that is getting filtered, that is not getting absorbed properly. So it's coming in the urine. So I can tell probably the injury lies in the tubule. It's a tubular injury. If both urinary and serum cystatin C is increasing, I can tell then there is a combined glomerular and tubular injury, which is common in many different acute kidney injury patients. That's why cystatin C can tell the site of injury. At the same time, cystatin C is something that is an endogenous marker, which is an advantage. It is supposed to rise immediately after the kidney insult has happened. So it's one of the ideal novel marker, but it's very costly, not very validated like creatinine. So that's why we don't use in practice yet. The second marker that you can get in exam is something called NGAL. That's called a neutrophil gelatinase associated lipocalin. And the third marker is something called a TIMP2, which is a matrix metalloproteinase. And fourth marker that is being proposed is RBP, that's called a retinol binding protein. And fifth marker is something called a KIM1, that's called the kidney injury molecule 1. And the sixth marker is something called a beta trace protein, that's called a BTP or a beta trace protein. And seventh marker we have is something called a interleukin 18. And the eighth marker we have is something called a alpha-1 macroglobulin. And the ninth marker we have is beta-2 microglobulin. And the 10th marker is we have something called a alanine aminopeptidase. The 11th marker we have is something called osteopontin. And the 12th marker we have something called clusterin. And 13th marker we have something called kidney specific alkaline phosphatase. And the 14th marker that is proposed is our NAG. And 15th marker that is proposed is something called alpha GST, that is glutathione S transferase. And I think that's it. Yes, we discussed on all the markers almost. Yes. So now we have all these markers, 15 markers I have told you, which are alternative and novel markers of AKI. Any of these markers can be asked in exam. Cystatin C is the most likely. NGAL, TIMP2, RBP, KIM1, beta trace protein, IL-18. Then you have alpha-1 macroglobulin, beta-2 microglobulin, alanine aminopeptidase, osteopontin, clusterin, kidney-specific alkaline phosphatase, NAG, and alpha glutathione S transferase, alpha GST. So we have so many markers of AK. These are the novel markers of AK. Of course, right now, I think you'll be understanding this one. Apart from the serum creatinine, another important diagnostic test that we tend to do and we tend to follow is the urinalysis. I mean, we know about urea. Urea is different. We don't want to discuss about that right now, which is not going to have that much yield in exam. But urinalysis is going to have a very high yield in exam. We are going to urinalysis. Urinalysis is a huge topic. Huge means it's such a huge topic. You have so many things under urinalysis. So right from your basic assessment to your sediment assessment, so many things are there. But typically, we use something called a urinary dipstick. So that's the first thing that you're going to do. Urinary dipstick. As far as the urinary dipstick is concerned, what are things that we can check with the urinary dipstick? The first thing that we're going to check is the specific gravity of the urine. Remember, based on specific gravity, you can divide into 3, where the specific gravity is in the range of 1.008 to 1.012. This category number 1, this is what we refer to as something called a isostenuria, which means normal specific gravity. If you have specific gravity in the range of less than 1.008, then it means hypostenuria, that is low specific gravity. If you have specific gravity more than 1.012, then that is hyperstenuria, that is high specific gravity. Usually isostenuria can happen in the setting of CKD patients. CKD, the typical example is chronic glomerulonephritis. That will be asked in an exam. Any CKD patient cannot be able to concentrate the urine, and irrespective of the clinical situation, they will be having isosthenic urine, which means they cannot increase the specific gravity. And this can happen in the setting of loop diuretics as well. So it can happen in the setting of acute tubular necrosis. It can happen in the setting of loop diuretics as well. So where they cannot be able to concentrate the urine. So hyposnuria means there is reduced urinary concentration. So you know where the reduced urinary concentration will happen. It will typically happen in the setting of low ADH states. So best example in this situation is a diabetes insipidus, or it can happen in the setting of excessive water intake, too much of water intake, psychogenic polydipsia. It can happen in that setting as well. But nevertheless, the most important is the low ADH states. Whenever hypersnuria means you are going to have a higher concentration, which means you're having a high ADH in this perspective, which means the best example is syndrome of inappropriate ADH secretion, or probably it could be due to RAS hyperactivation in the setting of volume depletion and dehydration, where the concentration will be much higher. So this is all about the specific gravity. Second thing that you'll be getting in the dipstick is the pH of the urine. So you know the normal pH of the urine is somewhere around 4.5 to 6.5. You know how to make use of pH in the exam. So remember, whenever the patient is having pH of more than 8, this is extremely high pH. There are two possibilities here. When the pH is more than 8 means it's a heavily alkaline urine. Either the patient is having a forced alkalinuria, or I can call it as an alkaline diuresis. The patient is taking so much of bicarbonate purposefully. You are producing a forced alkaline diuresis or an alkaline diuresis, which is used in some situations like myoglobinuria or a myoglobinuric AKE. Second situation, if the patient is not on alkaline diuresis, then definitely there must be some urea splitting organism in the urine. This is a very, very important point. Suppose if the patient is not having any ICU admission or alkaline diuresis going on, if the pH is more than 8, such an alkaline urine can happen only in the setting of a urea splitting organism for sure. That like Proteus, Klebsiella, some urea splitting organism is there, ureaplasma, some urea splitting organism in the urine. And that's usually in the setting of a Struve stone. You know that. So very classic. If the urinary pH is more than 6.5, in the setting of RTA, usually it indicates a distal RTA. That's not distal RTA, more than 6.5. 5.5 is enough to tell a distal RTA. We know that already. Maybe more than 6.5 means high bicarbonate in the urine. That's what it means. Then probably if it's more than 5.5 in a patient who is having a Norman-Gap metabolic acidosis. Now this will be the usual question in exam. Suppose the patient is already having a NAGMA, and if the urinary pH is more than 5.5, in this setting, you think about a distal RTA. That's usually the only one possible diagnosis that I can make. DRTA, that's a distal RTA. That's the most important thing in exam. So now after knowing the pH of the urine, but this is the most final, is the most important point, distal RTA. Now third one, we need to know about the blood and the protein. So first, hematuria. Hematuria is a huge topic. As far as hematuria is concerned, you need to know what do you mean by microscopic hematuria and what do you mean by macroscopic hematuria. These are very trivial definitions. Anything more than 3 RBCs, 3 or more RBCs per high power field is equal to microscopic hematuria. Macroscopic hematuria means it's a gross hematuria, gross blood. And whatever may be the case, most common cause of hematuria in the world is urinary tract infection. That's the most common cause of hematuria in the world, followed by stone disease. Glomerular disorders are not very common. And as far as the sediment is concerned, when you do a microscopy, in sediment analysis, so we call it as sediment analysis. This micro and macro can be told by dipstick itself. So you don't want sediment analysis. As far as sediment analysis is concerned, you need to know whether it's a glomerular hematuria or a non-glomerular hematuria. That's the most important thing. Non-glomerular hematuria means it can come from the kidneys itself. Kidney parenchyma that is in the tubules. It can come from our collecting area, or it can come from the ureter, or it can come from the bladder, or it can come from the urethra also. So this is a non-glomerular hematuria, basically. Whenever there is a non-glomerular hematuria, this RBCs are supposed to be something called isomorphic, which means there will be red blood cells, but they look in normal shape. They'll be isomorphic. They'll not look in abnormal shape. Plus, at the same time, there will be absolutely no RBC cast, no cast formation. So that's very important again. But when you get a glomerular hematuria, the two quintessential points that you need to know is the dysmorphic RBCs. And second one is RBC cast. So these are the two characteristic evidences of glomerular cause of a hematuria. Because when they pass through the glomerulus and they want, if the RBCs come through that filtration slit, that small filtration slit, and they come out into the tubules, by the time they come out of the glomerulus, they'll be battered and bashed and bruised a lot, and so that the shape of the RBCs will be altered a lot. So remember, dysmorphic RBCs can be of different types. It might look some abnormal shape, or it can be in the shape of acanthocytes, whatever may be the case. So these acanthocytes also are considered to be one of the spectrum of dysmorphic RBCs only. So which means there is a rule: if there is more than 40% of dysmorphic RBCs, or if it is more than 5% of acanthocytes, or even a single RBC cast, can tell it's a glomerular cause of hematuria. That's a very important point. At least 40% of dysmorphic RBCs, at least 5% of acanthocytes, or even a single RBC cast in practice can tell that it's a glomerular source of bleed. So that is the reason why seeing a dysmorphic RBCs and acanthocytes is not that important. Seeing a single RBC cast also can tell you that it is a glomerular cause of bleed. And that is why that is the most important point. Single RBC cast. Very, very important point. Clear? So as far as the blood is concerned, one more important point they will be asking you is, dipstick is showing strong positivity. This is a very common question in exam. Dipstick strongly positive for blood, but no sediments, which means you're not seeing any RBCs at all, no sediments. Where will you encounter this situation? Dipstick is strongly showing blood, but there is no sediment at all. Where will you encounter this? I'm asking you. What are the conditions that produce this? Yes, two scenario. One is either it should be hemoglobinuria. Hemoglobinuria is very common in the setting of intravascular hemolysis. We know that. Or it's a myoglobinuria. Either hemoglobinuria or a myoglobinuria. Usually in this situation only, you're going to get a dipstick positive blood, but there is no sediment. That's where your question will tell. Whenever you have this kind of discordant scenarios, always think about hemoglobinuria or a myoglobinuria in that setting. That's very important again. So, and again, the staining in the dipstick. So even if the dipstick is positive for blood, the staining pattern in dipstick can tell you whether it's a hemoglobinuria or myoglobinuria, or it's a really, some kind of a stain. Suppose if you have a granular or a punctate kind of a staining, granular or a punctate kind of a staining in the dipstick, that is usually suggestive of a true hematuria. But if you have more of like a diffuse kind of a staining, or we call it as a homogeneous kind of a staining in the dipstick with blood, then that will be suggestive of a myoglobinuria or a hemoglobinuria. So whenever you have a homogeneous type of a staining, it indicates a myoglobinuria or a hemoglobinuria. If you have a punctate or a granular kind of a staining, it goes towards a hematuria usually. That's another point that you need to know. So now we know hematuria is there or not. But whether it is significant or not is a question. Remember, one important point to notice, any painless gross hematuria, this is the first gold standard point. Any painless gross hematuria, especially in an elderly patient, age more than 40, is equal to cancer unless proved otherwise. So, which means you are suspecting a bladder cancer here, or even a renal cancer can present, but even though less rarely, less commonly. Usually it will be a bladder cancer unless proved otherwise. So here the next step, if they ask you, you have to go for cystoscopy. That's the next step. That's point number one. Second, any symptomatic hematuria, whether it could be microscopic or macroscopic, is likely to be significant, which means there is some underlying disease. Number three, any gross hematuria, gross blood that is coming, that is always significant, which means there is some definite pathology is there. That's what I mean. It's always significant that you evaluate for pathology. And number 4, if you have asymptomatic microscopic hematuria. Asymptomatic microscopic hematuria, whether it is significant or not, it is not just a single thing is not significant. It becomes significant if persistent. Only if the microscopic hematuria that is asymptomatic is persistent, then only it becomes significant. Persistent in the sense, like if you have more than at least 2 to 3 consecutive specimens, consecutive samples testing positive for microscopic hematuria. Samples are testing positive for microscopic hematuria that are taken 1 week apart at least. So in this situation, it becomes very significant. So these are some important points that they might be asking you in exam. See, remember, asymptomatic microscopic hematuria is significant only if it is persistent. What is the definition of persistence here? At least 2 to 3 consecutive samples taken 1 week apart test positive for the same microscopic hematuria. That becomes significant in that perspective. Remember, if you have a hematuria, does it becomes a reason for renal biopsy? Yes or no? Can you do a renal biopsy because you have hematuria? Indicated or not? Yes or no? Nobody's answering. Nobody wants to answer. No, that does not become an indication for renal biopsy. Remember, hematuria alone as an indicator for renal biopsy is very poor and pathetic sensitivity is there to pick up some disease. So you don't do really. I'll tell you what are the indications for renal biopsy after some time. So, I mean, these are the points that you have to really know about hematuria, especially this dysmorphic RBC section is very, very important as far as exams are concerned. Then after finishing hematuria, let us move on to the proteinuria, which is very important again. It's a very important thing in entire nephrology, proteinuria. But because it becomes an indication for biopsy, that's why any proteinuria more than 0.5 grams per day, unexplained proteinuria is an indication for renal biopsy. Okay, so proteinuria. So what do you mean by proteinuria? I mean, you should not confuse with albuminuria. There's something called proteinuria. First, for that, we need to know normal protein in the urine. Normal urinary protein. We'll talk about 24-hour urinary protein. Normal 24-hour urinary protein is less than 150 milligram per day. But in pregnant women only, you can keep a cutoff of 150 to 250 because they exceed a little higher. So 150 to 250 in pregnant women. But apart from that, normal urinary protein level is less than 150 milligram per day. So if you want to call it as a proteinuria, it should be more than 150 milligram per day. That's all. This is what we refer to as a proteinuria. Usually there is something called a glomerular proteinuria. It will be typically more than 0.5 to 1 gram per day. This is the usual glomerular proteinuria. But remember, in that itself, you have something called a nephrotic range proteinuria, which is defined as more than 3.5 grams per day. This is nephrotic range proteinuria. But whenever you call out a glomerular proteinuria, it will be more than 0.5 to 1 gram per day, irrespective of nephritic or nephrotic syndrome. But if it is nephrotic, typically called as more than 3.5 gram per day. But what is subnephrotic range proteinuria? Anything less than 3.5, but more than 0.5, we call it as subnephrotic range. Anything more than 3.5 is a nephrotic range. That's all. That's a glomerular proteinuria. Then apart from that, we have something called a tubular proteinuria, which will be typically in the range of 1 to 2 grams per day. It's very difficult to differentiate just by seeing the amount of protein, but these are some questions in exam. Tubular proteinuria typically will be in the range of 1 to 2 grams per day. And there are other types of proteinuria called as overflow proteinuria. Remember, tubular proteinuria will happen in the setting of a tubular damage. Glomerular proteinuria will happen in the setting of a glomerular damage. Glomerular damage. Remember, the one thing that tells you it's a glomerular proteinuria is predominantly it will be albumin. Albumin and globulins. Predominantly it will be albumin plus or minus globulins. So this will be the indicator of a glomerular damage, which means whatever that is present in the blood is coming into the urine. because the barrier is broken. Glomerulus is damaged. If it's a pure tubular proteinuria, most of the proteins that is coming in the tubules will be something called Tom Horsfall proteins. Predominantly, they'll be made of this Tom Horsfall proteins only. These are basically tubular proteins that are secreted. So if the tubular damages means, then majority of the proteins will be these kind of proteins only. Then there is something called a overflow proteinuria. Overflow proteinuria happens in the setting of multiple myeloma and monoclonal gammopathies because the proteins are produced in excess in the body. Because so much of proteins are there, something is leaking out and coming out. So this is an overflow proteinuria, and the amount of protein that is going to come out is variable in the situation. It can be nephrotic, it can be subnephrotic, but typically it will be made of predominantly light chains only. So in the sense, like you will be getting in the setting of a paraproteinemia, like a multiple myeloma or conditions similar to that. So this is how you classify the proteinuria. You can tell it's a glomerular proteinuria, tubular proteinuria, and overflow proteinuria. Or there is another entity called isolated proteinuria. Isolated proteinuria. So usually again the amount will be variable, but it will very commonly, most commonly be less than 0.5 grams per day only. So which means when you call it as isolated proteinuria, these patients will have a normal kidney function, normal urine output, and they look clinically normal. Clinically normal also, which means there is no problem at all, and there is no other sediments in the urine, which means whenever there is no sediments means we call it as a bland urine. So patient is having no sediments, normal creatinine, normal urine output, clinically looking normal. If they're having proteinuria only as a prominent finding, will be called as a, isolated proteinuria. Usually they will be very low, less than 0.5 grams per day only. One of the important reasons for isolated proteinuria in young adults is the orthostatic proteinuria. One of the important causes of orthostatic proteinuria, which means many of them will be young adults, especially young males, very commonly, who come with proteinuria will be orthostatic proteinuria. And it's not a problem at all. Even viral infection can induce this kind of orthostatic proteinuria. So it will resolve typically in a short period of time, maybe in 1 or 2 weeks or 3 weeks. When you repeat, it would have completely resolved. So to find out whether it's orthostatic proteinuria or not, there is some split urine collections also. For example, you do a 24-hour urine protein analysis. That's basically the gold standard for assessing the proteinuria. We know that. So to know whether it's orthostatic proteinuria or not, you will do a split collection, 16-hour, 18-hour collection. So 16-hour, 8-hour collection, 16 hours in the day and 8 hours in the night continuously. So which means in the morning, the patient will be awake and they will be walking around. So in the morning, when you collect that 16 hours, the protein content will be very high. In the night, when they lie down, the protein content will be very less. In fact, they won't have any protein at all. So that's orthostatic proteinuria, which happens in young males. Typically, and if at all they ask you a young healthy male who's coming with proteinuria, more than 90% of the times it will be an orthostatic proteinuria only. Or even some fever itself can induce proteinuria. Then stress, exercise, viral infections can induce this kind of proteinuria, which means it does not indicate any problem, which means to tell it's isolated proteinuria, you should have everything to be in the normal range. No sediments, clinically normal patient, no normal creatinine, no urine output. So, normal urine output. So these are the areas where you can tell it's a isolated proteinuria. So these are the 4 important different forms of proteinuria I need to tell. So of course, the proteinuria definition is anything that is more than 150 milligram per day is what we refer to as proteinuria. But remember, again, pregnancy should be an exception, isn't it? In pregnancy, if it is more than 300 milligram per day, you can call it as a proteinuria, because in pregnancy up to 250 is normal. More than 300 is the typical definition of proteinuria in pregnancy. You take and see your OBG textbooks also. You'll be coming to know 300 is the cutoff there. But in all other patients, it is 150 that is going to be the cutoff. So, but even though we call about this kind of, 24-hour urine protein as the gold standard, but the main problem with this 24-hour urine protein is the fact that it is very cumbersome and many patients will not be willing to collect 24-hour proteinuria. What is the best alternative? They ask you the best alternative for 24-hour urine proteinuria. What is the best alternative? Anyone can tell? What is the best alternative for a 24-hour urine proteinuria? Surrogate marker of 24-hour urine protein. You know, the gold standard is still 24-hour urine protein only, but what is the surrogate marker here? Yes, protein creatinine ratio. That's called a spot protein creatinine ratio. this protein creatinine ratio will be excellent. Usually they will be given in milligram per gram, but one of the best alternatives for and the surrogate marker for 24 urinary protein. But there are other ways to measure this urinary protein as well. For example, the dipstick protein itself is there. Dipstick quantification is there, but this is very weak marker of proteinuria. And remember, dipstick quantification is based on the concentration of protein. We are actually finding the concentration of the protein and we are not measuring the amount of protein per day. That's very important. For example, if the dipstick tells trace proteinuria means the patient is having 5 to 20 milligrams per liter. 5 to 20 milligrams per deciliter per 100 ml. So this is the amount of protein concentration in 100 ml. So we are not taking the per day, it's the per deciliter concentration of urine. Suppose if they tell 1+, that indicates you are having around 30 milligrams per deciliter of protein. If it's 2+, then approximately it is 100 milligrams per deciliter. If it's 3+, then it approximately tells 300 milligrams per deciliter. Or if it's 4+, it tells approximately more than 1 to 2 grams per deciliter. And there are many pitfalls in this dipstick. The major pitfall is its concentration. That's what you have to know. It's not basically the per day urine. That is very important in clinical setting that we are measuring here. So it's the concentration that we are measuring here. So that becomes one of the major pitfalls here. So which means the one important thing that it depends is on the specific gravity. Which means more the specific gravity, more will be, of course, the concentration of the protein in the urine. So lesser the specific gravity, protein concentration will be lesser. So only the normal specific gravity, you can tell that the patient is having how much protein, and it can, to an extent, depict the correct estimation of a protein. But it highly depends on specific gravity of the urine, concentration of the urine, number one. And second, dipstick is completely insensitive to a finding called a microalbuminuria. Microalbuminuria has many definitions, but according to dipstick, it is defined as less than 3 milligrams per deciliter. This is basically referred to as microalbuminuria. Less than 3 milligrams per deciliter, because trace means itself 5 to 20 only. They cannot detect this kind of very small albumin release, less than 3 milligrams per deciliter, so they cannot detect microalbuminuria. And they are completely insensitive to the detection of light chains and Bence-Jones proteins. They cannot detect light chains or they cannot detect the Bence-Jones proteins. They are insensitive to that as well. They cannot detect that also. Okay. Now, after knowing about this proteinuria, it's also important to know about albuminuria. So, what is the normal amount of albumin that is excreted? We are talking about 24-hour urine albumin. 24-hour urine albumin. What is the normal 24-hour urine albumin? That is less than 30 milligrams per day. That is normal. If you want to call albuminuria, anything more than 30 milligrams per day is supposed to be albuminuria. Suppose the patient is having, albumin in the range of 30 to 300 milligrams per day, albumin excretion. This is what we refer to as a microalbuminuria. Microalbuminuria, where dipstick is very insensitive. In dipstick, this microalbuminuria is defined as ones that are having albumin less than 3 milligrams per deciliter. But the real definition of microalbuminuria is albumin in the range of 30 to 300 milligrams per day here. Or if the albumin is more than 300 milligrams per day, this is equivalent to overt protein. Now, albuminuria doesn't have any value here. It's overt proteinuria. It's just protein, that's all. That's coming out. So there's no special name for that. So now if they ask you the best alternative or a surrogate marker of 24-hour urine albumin, that is urine ACR, that is albumin creatinine ratio. Even that is also there. So 24-hour urine protein, the surrogate marker is urine protein creatinine ratio. The best alternative for the gold standard 24-hour urine albumin is the urine albumin creatinine ratio, which is going to act as a surrogate marker for 24-hour urine albumin. But only one pitfall with this 24-hour urine albumin is the fact that they depend heavily on the creatinine, because the creatinine ratio, protein creatinine ratio, albumin creatinine ratio, they heavily depend on the creatinine. So again, the muscle mass will come into play. The more muscle mass, then there might be some bias, or very less muscle mass, again, there will be some bias. Apart from that, one of the best spot alternatives for 24-hour values is this protein creatinine ratio or albumin creatinine ratio only. We cannot do anything in that. So that's very important again. So remember, if you want to know how will you identify this glomerular and tubular proteinuria, usually the best evidence in reality will be sediments. Usually this glomerular damage and tubular damage will have some form of sediments will be there. I mean, for example, you might be an RBC cast, you can see a WBC cast, you can see a tubular cell cast, you can see a muddy brown cast. So some sediment evidence will be there. And there will be other evidences as well, like FeNA and all will be there. A lot of other evidence will be there. So sediments is one important sign of glomerular and tubular proteinuria. But overflow proteinuria, isolated proteinuria, definitely no sediments. Overflow proteinuria usually will not have sediments, because that is because of too much production of protein that is causing the proteins to come out of the urine. So that unlikely to have sediments unless until there is another kidney damage that is going on. So I think we have had a decent coverage on proteinuria as well, which is very important. So we have discussed 4 things. Then as we move on to the 5th one, we have glycosuria. I think we have discussed a detailed discussion on glycosuria already. When you have a glycosuria with normal urinary threshold, when you have a glycosuria with reduced urinary threshold, we discussed that already. And the next thing is other investigations in the urine, like leukocyte esterase. What is the importance of the leukocyte esterase? Normally it should be negative. Whenever there is WBCs, especially neutrophils in the urine, they'll produce a positive leukocyte esterase response. So leukocyte esterase means it's a granulocyte esterase, which means they are detecting WBCs in the urine, especially neutrophils in the urine. Remember, I told you in Kawasaki disease itself, leukocyte esterase will not detect lymphocytes. Will not detect lymphocytes. If leukocyte esterase is positive, it means WBCs are there in the urine. It is not telling you that there is an UTI or not. Just tell you WBCs are there, especially the neutrophils are there in the urine. Remember, the leukocytes that are coming in the Kawasaki disease lymphocytes. That's why I told you there leukocyte esterase will be negative in that situation. And second, we have nitrate testing. This nitrate is for Enterobacteriaceae. This is for UTI only. This will tell you the WBC, but this is for checking for urinary tract infection, nitrate positivity. Because usually you are going to give nitrate only. Let us write here, nitrate only. So this nitrate can be converted to nitrate by something called nitrate reductase. This enzyme will be present in Enterobacteriaceae. Enterobacteriaceae species will contain this nitrate reductase enzyme. So because of that, it will be converted to nitrate, and this is what is actually detected with in the dipstick. So whenever nitrate is positive, nitrate test is positive, it indicates a UTI with Enterobacteriaceae, like E. coli, Pseudomonas, or some similar agent. But if the UTI is due to non-Enterobacteriaceae species, your nitrate may be negative. So you have to be very clear. If nitrate is positive, it usually indicates a UTI. But if nitrate is negative, that does not indicate a UTI. Please understand. Nitrate is negative means, nitrate negative means it's not like it does not indicate a UTI. There could still be a UTI, but it's just the fact that it's not an Enterobacteriaceae. That's all. So you cannot rule out a UTI based on nitrate becoming negative. Nitrate positivity strongly correlates with urinary tract infection. And next, ketones. Urinary ketones are very, very inferior and poor because urinary ketones measure acetone basically. And probably they measure acetoacetate by a reaction called nitroprusside principle. They are going to use nitroprusside dipsticks only. Using nitroprusside, you can find out the urinary acetone. Remember, this is the same principle behind your traditional first year ketone testing, that is Rothera's test. You would have seen something called Rothera's test in your first year. And Rothera's test is basically based on the nitroprusside testing only. Acetoacetate are basically inferior, and they don't reflect the exact value of ketones. For example, in a diabetic ketoacidosis patient, the beta hydroxybutyrate is the most important ketone body. And normally, beta hydroxybutyrate to acetoacetate in the body will be in the ratio of 1:1 in normal setting. But in setting of diabetic ketoacidosis, it becomes 10:1, which means the beta hydroxybutyrate is the most important in the setting of a ketoacidosis. And this acetoacetate is the one that disintegrates or changes to acetone and these two are the things that are detected by urine testing. Urine nitroprusside testing basically detects this acetoacetate and acetone only, which is not even important in diabetic ketoacidosis. And beta hydroxybutyrate is the most important. So now don't use urinary ketones which are inferior. Instead use plasma beta hydroxybutyrate. plasma beta-hydroxybutyrate, direct levels are there, and these are going to be more accurate for our DK assessment or any ketosis assessment. Urine ketones are highly inferior. So that point we need to know definitely. And then you can assess bilirubin also. Bilirubin can be assessed. Remember, whatever bilirubin that is coming in the urine is the conjugated bilirubin. Please understand, unconjugated bilirubin cannot come in the urine. It detects conjugated bilirubin only. Unconjugated bilirubin will not pass the glomerulus because it is bound to albumin. Very, very important point. Unconjugated bilirubin is bound to albumin. Unless and until there is albuminuria, unconjugated bilirubin will not come out of the glomerular filtration barrier. And number 10 is we have urobilinogen. This can also be detected. Remember, the most important idea about this urobilinogen is the fact that it's a marker of enterohepatic circulation. Urobilinogen is normally present, normally seen in the urine. Urobilinogen, even in jaundice it will be seen, but in one jaundice it will be absent. If it is negative, it indicates an obstructive jaundice. Because in obstructive jaundice there is no enterohepatic circulation that is happening, which means there is a blockade in the bile flow. If the bile doesn't flow, how can there be enterohepatic circulation? So urobilinogen is a marker of enterohepatic circulation. And if it is not there in obstructive jaundice, it will be negative. So this is a very important point. So whenever urobilinogen is not there in the urine, it is indicative of a obstructive jaundice in that scenario. So these are the things that I'm going to assess using the dipstick. So we have discussed right from our specific gravity to the urobilinogen. So now the next thing is my sediment analysis, which is very important. And this is a very important question in exam. As far as sediments are concerned, I can look for the cells. I can look for the cells directly. Then I can look for the cast, and I can look for the crystals. These are three things I can look for whenever I go for a sediment analysis. As far as cells are concerned, I can look for the RBCs, but one of the important things I need to look for the RBCs, whether they are isomorphic or dysmorphic, whether isomorphic versus dysmorphic, whether isomorphic or whether they are dysmorphic. This is what I need. If it's isomorphic, extraglomerular cause. If it's dysmorphic, it is glomerular cause. Usually, but the percentage is again important. Or I can see WBC. Seeing WBC in urine indicate a urinary tract infection, or it could be seen in interstitial nephritis, or it can be seen in glomerular nephritis itself, which means it's a highly non-specific thing. And you can see epithelial cells in the urine as well. Epithelial cells in the urine are again non-specific. It can come from the renal tubules, which have epithelial cells. It can come from the urinary bladder, which has epithelial cells. It can come from the urethra, which contains epithelial cells. It can come from the vaginal epithelium or from the foreskin in the penis, which can have epithelial cells. So again, it is not a very typical finding of any particular pathology. So that's again non-specific. But the most important is this isomorphic versus dysmorphic RBCs in the cells. Apart from that, you can see something called oval fat bodies. Oval fat bodies, these are also the cells. And this is a multiple times asked question, oval fat bodies. Oval fat bodies are nothing but something you see. These are lipid droplets that are contained in the tubular cell. So for example, if you have a tubular cell that contains these lipid droplets, tubular cells with lipid droplets. So these are called as oval fat bodies. And more importantly, when you put in polarized microscope, when you examine these oval fat bodies, these are tubular cells in polarized microscope, they show a multi-cross fluorescence, or they'll show a multi-cross glowing or multi-cross appearance will be there. That's suggestive of, whenever in polarized microscope you get a multi-cross appearance, that is suggestive of a oval fat body, which means that these are nothing but tubular cells that are shed down and that is containing increased lipid droplets. So which means oval fat bodies can be seen in setting of nephrotic syndrome, number one. And more importantly, they will be asking about Fabry disease. That was the last AIIMS exam question. So in Fabry disease, you can see oval fat bodies, and at the same time you can see in polycystic kidney disease as well. These are the three conditions where you can see oval fat bodies, but more important, very common in nephrotic syndrome. But in exam, usually they might ask you about Fabry disease also, where you can see this multi-cross type of appearance in polarized microscope, suggestive of oval fat bodies. And number 5, there is something called bubble cells. Bubble cells are also there. Bubble cells, on the other hand, these are vacuolated tubular cells, again seen in acute tubular necrosis. tubular injury. Any tubular injury can produce this kind of bubble cells, non-specific. But in exam, if they specifically ask, you can tell acute tubular necrosis. These are nothing but vacuolated tubular cells, not lipid droplets. Vacuolated tubular cells that are shed down in response to tubular injury, typically in the setting of acute tubular necrosis. Then next comes the most important, the CAS. The CAS are very important. You can basically divide into cellular cast and acellular cast. I'll come back to that in some time. But what is basically a cast? If you have a tubule, you have a glomerulus and a tubule. Suppose if there are some cells or some substances that are coming into the tubules, and you know these are going to get shed down. So which means they form an organization within the tubule. So once they come in the urine, they're going to look something like that. So which means if they look something like that, means they are basically cylindrical in structure. Why cylindrical in structure? Because they take the shape of the tubules in which they are formed. In which area if they are formed, they are asked. Typically they are formed in the PCT and the DCT area, the proximal convoluted tubule and the DCT, distal convoluted tubule. The formation will start in the PCT, but usually it end in the DCT. So it's a continuous process where they are shaped off in the shape of the tubules itself as they pass through the tubules. When they come out of the urine, they come in the shape of the tubules itself, just like that. So it's like forming, that's why they're called as casts. You can understand, it's like a plaster of Paris cast, you know, you take the shape of that particular structure. It's like that, say that cylindrical structure, tubular structure, that take the shape of the tubules and they come out in the urine. So where you can identify them. So you can basically divide into two. One is called as cellular casts, and second one are basically acellular casts. As far as cellular casts are concerned, we have the most important RBC casts. Whenever RBC casts are there, the only one condition that you need to diagnose is glomerulonephritis. That's all, nothing else. There's only one possibility. RBC casts are the most important. Even a single RBC cast in the urine will tell you that the patient is having a glomerulonephritis. Or you can have a WBC cast in that perspective. WBC cast typically tells you where the patient may have glomerulonephritis again, or the patient is having interstitial nephritis. I can write IN for now. Later on I will explain. Interstitial nephritis, or the patient may have a pyelonephritis. In these three scenarios, you might get WBC cast, which means it's not very specific. Or you can get this kind of tubular cell cast. Tubular cell cast. These are also referred to as something called epithelial cell cast, typically seen in any tubular injury. The best example is acute tubular necrosis. And fourth one, we have something called a muddy brown cast. Muddy brown cast. As far as the muddy brown cast, this is also referred to as something called a granular cast. These are the sloughed up tubular cells, which means these are the tubular cells that are damaged in the setting of an acute tubular necrosis. This is a very important question in exam. What is the type of cast that will tell you it is an acute tubular necrosis? It is muddy brown cast, otherwise referred to as granular cell cast. Acellular cast, basically we have something called hyaline cast. It's a completely normal finding, or it can indicate an increased urinary concentration. If you see in more number, they just indicate increased urinary concentration. Increased urinary concentration sometimes can happen in a prerenal AKI. It's not specific for prerenal AKI, but in exam they specifically ask you, it can be seen in prerenal AKI, but does not have any significance, no value, non-specific finding. Or you can have a fatty cast. Fatty casts are typically seen in nephrotic syndrome, that is accumulation of lipid droplets, nephrotic syndrome. As the name suggests, it's fatty. Then you have something called a broad waxy cast. Broad and waxy cast, they are typical findings in a chronic kidney disease, CKD. Whenever they give broad waxy cast in exam, always go for a CKD. If you want to tell three important casts in exam, RBC, muddy brown, broad waxy. These are three important casts in exam. Remaining, you may, remember if you want, otherwise you can forget. But this is really, really important and very, very important in our exams. So what about the crystals? What are the crystals here? As far as the crystals are concerned, we have many, many different types of crystals that can form, and that needs a separate discussion. In a sense, like I'll tell you the few important points with regards to crystals, and I'll show you some images also, because I have got a lot of images which I'll show you. The first one is the calcium oxalate. Calcium oxalate crystals. So how the calcium oxalate crystals will look like? It will look like as if they are something called a bipyramidal shape or envelope shape. Calcium oxalate crystals will look like this kind of envelope shape, or you can call it as bipyramidal in nature. Bipyramidal or envelope shape. So usually calcium oxalate has two types. One is dihydrate crystals. Calcium oxalate dihydrate will look typically like this. Or you can have calcium oxalate monohydrate crystals. In exam, if they ask you where will you see calcium oxalate monohydrate crystals, you should answer, I will see in ethylene glycol poisoning. That's where I will see. In fact, that is the reason for acute kidney injury that you see in ethylene glycol poisoning. It's a car coolant. Calcium oxalate monohydrate crystals. These monohydrate crystals can look like sort of a needle shaped also. So number 2, second group of crystals is calcium phosphate crystals, or otherwise referred to as bruchide crystals. Calcium phosphate crystals. Calcium phosphate crystals can be seen as asymmetric rod-like structures, not be symmetric. Asymmetric rod-like structures. So I can write asymmetric rod-like aggregates. That's calcium phosphate. Number 3, then we have cystine crystals. Cystine crystals, which are basically hexagonal in shape, very characteristic, easily identifiable in images also. Hexagonal shaped crystals. And number 4, we have the triple phosphate, that is magnesium ammonium phosphate. Triple phosphate crystal or struvite crystals, typically said to have a coffin lid shape. Coffin lid like kind of a shape. You should not confuse the envelope. This will have a little different shape. Coffin lid kind of a shape. That's typical. Uric acid crystals will look little different. They can look like lozenges and they can look like kind of tablet form of shape will be there. I'll show in the image. So a lot of drugs also can cause crystal formation in the urine. So the most important drug in that setting is the sulfur drug. Sulfur drug crystals is very commonly asked in exam. Usually they will be like a shocks of wheat. They'll be like this. These are called as like shocks of wheat or shocks of needles or shocks of wheat. You can call it in any way. So that's how your sulfur drug crystals will be there. Especially these drug-induced crystals will be seen pronounced in volume depletion states. Drug-induced crystals are pronounced in volume depleted scenarios. When the patient is not taking sufficient water, the crystals may be very prominent and pronounced. Then we have Indinavir crystals, which will have typically a starburst appearance. I'll show you the image, then you will understand. Starburst kind of an appearance. And you have acyclovir crystals, which have again typical shape will be there, like again needle shaped crystals, needle like this. Acyclovir crystals. And apart from that, crystals can be induced by other drugs also, like for example, methotrexate is there. Then we can get with ciprofloxacin, we can get amoxicillin. So many other drugs are there. Then triamtrin can induce production of crystals. Triamtrin is there. So many things can develop crystals, but more importantly, this sulfur is very commonly asked because this is very characteristic shape. That's why they give an exam. Indinavir and acyclovir are also important. These, if you want to remember, otherwise you can forget, no problem. Methotrexate, ciprofloxacin, amoxicillin, even triamtrin, all these things can produce crystals. So these are the crystals that we need to remember for exams. And let me show the images. Let me load the images. I think only 10 images can be loaded. Okay, you are going to answer from the top. So what is this one? To start with, what is this one? No, this is a muddy brown cast. I don't think you see any cells here. I don't think you see any RBCs here. This is the typical example of a muddy brown cast. This is not an RBC cast. RBC will be a little more pronounced and it will not be much concentrated like this. This is a typical example of muddy brown cast or a granular cast that you see. So typical example, acute-tubular necrosis. What is this one? Any idea? Yes, this is a WBC cast. This is a WBC cast because you are seeing a nucleus. You can see a nucleus here. So that's typical of a WBC cast, straightforward. So it is non-specific, can be seen in pyelonephritis, interstitial nephritis, even glomerular nephritis. Okay, then what about this one? So here I want to show these cells. What are these cells? What are these cells? Yeah, but more importantly, we have wanted to show the dysmorphic RBCs. Whenever you see this kind of excessive dysmorphic RBCs, it's a glomerular cause of bleed. I think this image is not there. Okay, it came at the last. Okay, fine. What is this crystal? This particular crystal that we are seeing. It's not Indian average basically. I mean, you are thinking about a starburst appearance here. No. This is actually a uric acid crystal, which are not discussed. That's why I told you uric acid is something that will be very different. Uric acid crystals will look like as if there are rosettes are there. I mean, this is an example of a rosette, and plus they will be looking like a rhomboid shape also. That's why I told you a rosette here, and there is a rhomboid shape crystal as well. So this is a typical uric acid crystal. This is how it looks like, rosette rhomboid. So that's characteristic of a uric acid crystal. And more importantly, if you want to confirm that it's a uric acid crystal, you have one confirmation method also. You can actually put this uric acid crystals, in polarized microscope, and you can see the fluorescence that look usually pink in color. So in Woods lamp also. So that's one example where you can see uric acid crystals. But more often in exam, if you get this kind of rosettes and rhomboid shaped crystals, it goes towards a uric acid crystal. What is this type of crystal? We discussed that already. Yes, this is monohydrate crystal. I mean, this is not monohydrate. These are bruchate crystals, calcium phosphate. Bruchate. I told you, asymmetric rod-like shape. We drew already. I think we drew the exact same picture. Asymmetric rod-like structures. Bruchate crystals. These are not needles. These are rods. How can you confuse this with needles? This I'll tell you, you will not be able to predict. These are basically the acyclovir crystals that we are seeing. These are needle-shaped acyclovir crystals. And what are these crystals? These are the classic calcium oxalate dihydride crystals that you see. Envelope shape. Calcium oxalate dihydride crystals you are seeing. These are typically envelope shaped calcium oxalate dihydride crystals. Typically seen like your routine stones. This is how it looks like. Remember, this is the envelope that we see. And what are these cells? These are epithelial cells. They're round in color. I mean, round in structure, epithelial cells. What is this cast? This is the characteristic RBC cast. see the difference between the muddy brown cast. It will be more concentrated and packed. It will be little loose RBC cast. And more importantly, these are cells that are not having any nucleus at all. So it's not a WBC cast. This is a typical example of an RBC cast. And this is a cystine stone. Not cystine. This is a cystine stone. Or a cystine crystal, hexagonal in shape. This is a typical coffin lid appearance. So that is very characteristic of a triple ammonium phosphate kind of a crystal. Coffin lid shape. This is a true white crystal. What is this? This is characteristic. That's why they give you this thing in exam. What is this one? Ashutosh is telling Indian average. How it can be Indian average? This is very clear actually. Sulfur. I drew already. This is shocks of needle kind of an appearance or shocks of needle kind of an appearance. This is typical sulfur. More often in exam, you will get this and you will get this, you will get this, you will get this, then you will get this, you will get this, and you will get this. This is the most important, top of the list, muddy brown cast. So these are the different crystals and casts that they're going to get in exam, and be very clear about that. And they can ask any different image also, but you should know how to identify them. And especially when they will give a clinical background, usually they won't give just an image and they will ask you how to find out. They basically give some clinical background. Based on that, you can easily find out. Not a big deal. This must be easier for you. Yes, urine analysis over. Even our renal scans are also over. Only one final point with regards to diagnostic aspect of nephrology is what is the normal ultrasound size of the kidney below which you will tell it is abnormal? Can anyone tell? Ultrasound size of the kidney below which you can tell it is clearly abnormal. Overall, what is one size you tell? Correct, 9 to 11 centimeters is actually correct, but what is one overall size below which you can predict probably the kidney is small? 10 centimeter. That's a universal, even though Asians have a different cutoff, but still universally 10 centimeters agreed to be the definition of small kidneys. Overall, females will have around 9.8 to 11 centimeter. Males will have 10.2 to 12.4 centimeters. This is a normal average mean kidney size in its largest dimension. So you can, overall, you can assume that anything less than 10 centimeter, you can tell it as a small kidney. But remember, small kidneys alone is not significant. If they give small, which means less than 10 centimeter, plus echogenic kidneys, which means there is loss of corticomedullary differentiation, then that becomes significant. This becomes something like a chronic kidney disease. Small echogenic kidneys, that is a problem. If they give only small kidneys, even with a preserved echogenicity, which means if there is a significant corticomedullary differentiation that can be made, then that does not become significant at all. If they give small and echogenic kidneys, which means if the corticomedullary differentiation is lost, then in that setting it becomes very, very significant. That's all. So kidney size. Okay. Ultrasound is a very important investigation. So let us finish off the imaging also. Among the entire imaging, ultrasound is the most important as far as kidney is concerned because it's non-invasive and they're going to look out a lot of parameters. In that, the most important thing that you're going to look out is the size of the kidneys. At the same time, the pelvis, ureters. And remember, one of the important pitfalls of ultrasound is the lower part of the ureter cannot be seen. Ureters, only the upper 2/3 of the ureter can be, upper 1/3 of the ureter can be clearly seen. The lower 2/3 of the ureter are very difficult to see because it's obscured by the bowel gas. That's why stone disease in the ureter, ultrasound is not a very sensitive investigation. But stones in the kidney, stones in the upper part of the kidney, upper ureter, they can pick up very nicely. Because lower 2/3, especially in the area of the pelvic brim, it's very difficult to find because it will be completely obscured by the bowel gas. That's the reason. So size, pelvis, then perinephric collection. Perinephric area can be seen very nicely. And even if there is any presence of cysts, you can see the parenchyma of the kidney in the form of corticomedullary differentiation. If the corticomedullary differentiation is lost, then only we are going to call it as a fully echogenic kidneys. So CMD is very important. CMD lost in a kidney is equal to that of a lost kidney. It's not a CMD lost, it's a kidney lost. So it's an echogenic kidney. That's all. So based on the size, I can tell small kidneys. Small kidneys means I assume it must be less than 10 centimeter. Many times if small kidneys are seen bilaterally, that usually indicates either a CKD or a significant renal scarring. Bilaterally, if you see very small kidneys, indicates a CKD or a complete renal scarring. That's what it indicates. On the other hand, if you see a large kidney, and if I think bilateral large kidneys, what are the differential diagnoses for a bilateral large kidney? The first differential diagnosis, hyperfiltration, that is going on. So what are the conditions where you can have a hyperfiltration related scenario? The first condition I'm going to tell is diabetes mellitus. Very important condition where I can have a hyperfiltration. Long-standing chronic hyperfiltration, diabetes. Second, I can get in the setting of obesity, severe obesity, because kidneys need to work harder for that extra blood and that extra fat they are having, so that they need to work extra. They need to purify much faster. So that's where you get hyperfiltration. And second area where you can get is infiltration. So which means if the kidneys are infiltrated, especially the interstitium of the kidneys are infiltrated with some issue. Whenever you talk about infiltration, usually you know that in cardiology times itself we are speaking that it is amyloid, which is very important. Or it could be a lymphoma, or it could be a sarcoidosis. Clear? And hyperfiltration can happen with another setting called FSGS. I mean, FSGS is not a this thing, it's a biopsy diagnosis. So that's why I'm not using the word FSGS, but FSGS is important for exams. Why I'm telling is because obesity itself can cause FSGS. There are other conditions which can cause FSGS, like HIV-associated nephropathy can cause FSGS. So if you call HIV-associated nephropathy, they can also produce FSGS. And because of that also you can result in hyperfiltration. And because of that you will result in something called large kidneys. So FSGS is a biopsy diagnosis. FSGS is not basically a disease to start with. It's an histological diagnosis. That's all. Then second, I mean, other things when you talk about ADPKD, autosomal dominant polycystic kidney disease, where there will be a huge kidney because of the multiple cystic transformation. Apart from that, if you have interstitial nephritis, sometimes, especially acute interstitial nephritis, or if you have an IgG4 related disease. So in these settings also you might have a bilateral large kidneys. But more importantly, in exams, what you will be getting is diabetes, FSGS, amyloidosis, ADPKD, and HIV-associated nephropathy. So these are the things usually you'll be getting in the setting of exam. So whatever I underlined it, it's very important for exam. Just note that. Or third possibility is you can see a bilaterally small kidneys. I'm sorry, asymmetric kidneys. One side small and one side big, like that. Asymmetric kidneys. Asymmetric kidneys means is defined as at least more than 1 centimeter size discrepancy on either side. The kidneys are differing in size by at least 1 centimeter on either side. That's called asymmetric kidneys. Asymmetric kidney can be physiological sometimes. Physiological hypertrophy will be there. Especially it can happen post nephrectomy. Or like if there is a contralateral disease. Let us assume if there is a significant contralateral disease, that one side kidney, because one side kidney's function is lost to a great value, another side has to go for compensatory hypertrophy, like compensatory emphysema that happens in lung disorders. So because of that also you might have a physiological hypertrophy of the kidney. Apart from that, we can suspect whenever there is a pyelonephritis, very common entity in our practice. If you have a unilateral RAS, renal artery stenosis, I told you one side because of hypoperfusion they go for small size, other side there might be big. Renal vein thrombosis. That side because of congestion the kidneys will look a little big. And if the patient is having a renal infarction, that side will go for shrinkage, renal infarction. So these are some of the examples of an asymmetric kidney. Some congenital malformations are also there, which I don't want to tell now. But nevertheless, one kidney, in the sense certain patients congenitally they'll have only one functioning kidney. That's called a single functioning kidney. So many patients are like that. If you see in the OPD itself, they'll be doing well. They won't have any problem, but they will have only one functioning kidney. So another kidney will go for atrophy and they will shrink due to some congenital malformation, congenital issues that is happening in the time of birth. So these are the usual causes for a asymmetric kidney where there is more than 1 centimeter size discrepancy. Remember, as far as size is concerned, you need to know what is small. Small means less than 10 centimeter. Bilaterally small means indicates a significant bilateral renal scarring and CKD. Bilateral large kidneys, the most important is diabetes, FSGS, HIV, amyloidosis, ADPKD, very important causes. Asymmetric, it could be physiological, but it can be polynosis. Unilateral RAS is a very important cause. Renal vein thrombosis and renal vein infarction is also important cause of having a bilateral asymmetric kidneys in the body. And you can use, I think, nuclear imaging we have discussed already, so I'm not going to discuss about that again. So the DMSA, TTPA, MAC3 we have discussed already, so that's not something very important. And ultrasound Doppler is there. Doppler imaging typically used for two settings. One is renal artery stenosis and second is a renal vein thrombosis. These are two areas where we'll be using a Doppler imaging of the vessels, artery stenosis as well as renal vein thrombosis. Both the setting Doppler will be extremely useful. And number 4, CT and MRI only in selected situations. Select situations, not in all the cases, especially if you want to stage a cancer, or if you, for example, if you ask one important point about CT, CT is the best investigation for any stone disease in the kidney or bladder or maybe anywhere. If you want to know about the stone disease, CT is the best investigation. But even though first investigation we use ultrasound for stones, but the best investigation is the CT scan only. That is a non-contrast CT because they can see the stones much better because of the calcium content. So you have some advantages and some unique disadvantages as well, but the most important advantage is the stone disease as far as the CT is concerned. So ultrasound is the most common and the most important investigation that is performed in kidney disorders. Fine. And this table is very important, as I told you. And I think this completes our diagnostic strategy as far as the kidneys are concerned. So I think it's better we can stop today and I'll come back on another day. Yeah, biopsy, kidney biopsy. Yeah, somebody is reminding me, Ankit. What are the indications for kidney biopsy? As far as indications are concerned, the first indication is unexplained AKE. That's the first indication, which means you don't have explanation for that kidney injury. Then you're going to do a biopsy, number 1. Second is unexplained proteinuria, especially if it's in the glomerular range, more than 0.5 to 1 grams per day. So then definitely you have to, do the kidney biopsy. So these are the usual 2 indications where you do definitely a kidney biopsy. Apart from that, I generally don't want to do a kidney biopsy in other situations because it will not alter the diagnosis, especially if it is associated with active urinary sediments. Active sediments, I can do a biopsy. But any unexplained proteinuria, if it is more than 0.5 to 1 gram per day, which I cannot explain with any other reason, then I can do a biopsy. Number 3, maybe I can write RPGN, rapidly progressive glomerulonephritis, RPGN. Can you tell when you will call an RPGN? You will have glomerulonephritis. How will you classify glomerulonephritis? Based on the progression. Acute glomerulonephritis is there, RPGN is there, and third we have chronic glomerulonephritis. No. Ashutosh is telling crescent formation. Crescent is characteristic of RPGN, but acute glomerulonephritis happens in days. RPGN happens in weeks, usually approximately around 6 weeks. This is the time. Chronic happens in months. This is how progression wise you can split the glomerulonephritis. Acute glomerulonephritis, RPGN and chronic. RPGN always is equal to crescents. Whenever there are crescents, it's equal to RPGN. RPGN means is equal to crescents. That's something vice versa that we use in clinical practice. But based on the progression, how to tell RPGN? It is, if it's happening in weeks, like it's 6 weeks. Within 6 weeks, if the creatinine doubles, that's what they tell. So if the creatinine is keeping on increasing, that is suggestive of a rapidly progressing glomerulonephritis. Some of the important definitions I'm talking about. So these are the 3 areas where I'm going to do a kidney biopsy. Clear? Why I'm telling? Because some students will ask, clever students, RPGN. Sir, RPG, I mean, because your understanding is poor, RPGN is crescent. Where will you find the crescent? In biopsy. We are talking about an indication for biopsy and how we can call RPGN without crescent based on the progression only. If it's 6 weeks, the creatinine doubles. The creatinine is rising over a period of 6 weeks continuously without any droppage or without any plateau, then I can call it as a rapidly progressing glomerulonephritis. You have certain contraindications also. There are a lot of contraindications for renal biopsy, but there are only very few absolute contraindications. What are the absolute contraindications? Number one, of course, an uncooperative patient, because kidney biopsy needs the patient to cooperate in a particular position and all this stuff. So if they are uncooperative and if they are not able to follow instructions in ICU, altered mental status, you cannot do it. And you will end up in more harm than doing some benefit. So don't do biopsy in that setting. If the patient is having uncontrolled bleeding diathesis that is uncontrolled, so you cannot do, especially uncontrolled. If it's controllable bleeding diathesis, then you can do. For example, if it's a thrombocytopenia, you can transfuse platelets, make it around 50-70,000, then you can do a biopsy. Suppose if the patient is having uremic bleeding, because of uremia itself, the patient might have severe bleeding. If it's an uremic bleeding, in that setting also, you can correct the uremia, take the patient for dialysis, 1 or 2 sessions. After dialysis, you can do a biopsy. So if it's controllable, then not a problem. It's uncontrolled bleeding diathesis, then it's definitely a contraindication. Then again, uncontrolled hypertension. Uncontrolled severe hypertension. We know what you mean by severe hypertension. If it's more than 180/120, then in this setting also, it's an absolute contraindication. These are only 3 absolute contraindications as far as kidney biopsy is concerned. But nevertheless, you have many relative contraindications. Many relative contraindications. The best relative contraindications only I will tell you if the platelet count is less than 1 lakh, if the hemoglobin is less than 8 grams per deciliter, or the patient is having INR more than 1.5 or elevated APTT due to any cause, or the patient is having liver cirrhosis of liver, or if the patient is having solitary kidney, because there is some risk of CKD after biopsy. I mean, in the sense the kidney might go for involution after biopsy. Very few, I mean, small chance, maybe 0.05%. But if it is solitary kidney, we don't want to take a risk. Then the patient is having multiple bilateral cysts. I mean, we are talking about ADPKD. Why you want a biopsy in ADPKD? That's absolute nonsense. And the patient is having echogenic small kidneys. Echogenic small kidneys, which means here we are discussing about a CKD. So the question is, if there is echogenic small kidneys, it means you're dealing with the CKD, bilateral small kidneys. And what you're going to gain by doing a biopsy. If you do a biopsy, that should alter your management. You are going to find out something that's going to alter your management. If you know, like it's a CKD already and your management is not going to change, why you are going to do a biopsy? So again, you don't need to do a biopsy here. Rarely you can do a biopsy if you're doing a transplant and if you specifically want a diagnosis, because after transplant, you need to know whether the disease will come back again and will haunt the patient again or not. So in that setting, you might be needing a biopsy, but routinely, if it's an echogenic small kidney, I don't do a biopsy. Or if there's any congenital malformation like horseshoe kidney, or probably some other malformation, it becomes a relative contraindication. Then if the patient is having ESRD, end-stage renal disease, of course, I'm not going to do a biopsy. Active infection somewhere, for example, UTI, pyelonephritis, any intra-abdominal infections, perirenal abscess. So I don't do a biopsy. So these are relative contraindications, but it's important to note the absolute contraindications. Uncooperative patient, uncontrolled bleeding diathesis, and uncontrolled severe hypertension. Because when I tell the bleeding diathesis, immediately the students will tell, like, sir, what about uremic bleeding? So you can control with 1 or 2 sessions of dialysis. Once the uremia becomes okay, then you can do a biopsy, not a problem. So, but remember, if the patient is suffering from uremic bleeding, that becomes definitely a contraindication for doing a biopsy at that point of time. So there is a high risk of bleeding. So whenever the patient is having uremic bleeding episode, so do dialysis, reduce the uremia, then you take for the biopsy. That's a better option, as far as we know. Okay, fine. The most common, like post biopsy complication is the hematuria. Hematuria is the most common post biopsy complication. Most of the times it will be uneventful. If they ask you the most common post biopsy complication, it is hematuria. Usually it will resolve over a period of time. If in exam, if they give after a kidney biopsy, if the patient is having severe pain, loin pain, along with that there is a dramatic drop in the hemoglobin or hematocrit, usually they are trying to tell you it's a retroperitoneal hematoma. So think that. So if there is a drastic drop in hemoglobin with a lumbar pain, loin pain, and the patient is getting hypotensive, BP is dropping. So these all tell it's a major bleed, usually in this setting. Very rare, but you can diagnose a retroperitoneal hematoma in that setting. So I think kidney biopsy is also done. So some important points. I think we had a good discussion today. Both the sessions were good according to me because kidney is big, but still all these are important. So let us see in the next session. I'll inform when is going to be the next session. So I think I need one more day for kidney, not one full day, maybe half a day for kidney. Then I'll be taking hepatology. After that, 1 day of hepatology is enough. Then I'll be discussing on probably endocrine and respiratory system in short, because electrolytes already over. As much as possible, I discuss the electrolytes. Only calcium is left, which I'll discuss on endocrine. Respi is also very short because ABG is done, means respi must be much easy. Only few things will be there. I think another 2-3 days must be fine. 3 days must be fine according to me. I'll tell you, we'll be finishing within this month itself. No doubts about that. So I'll tell you when the dates are. Hemat, like usually in this kind of revision sessions, I don't do hemat and GIT because hemat as such is students still more of a pathology topic, and they don't need my help anyway. That's what the students think. And as far as GIT is concerned, again, there will be too much overlap with surgery, like especially when you think about a revision kind of sessions and all. If you take esophagus, there will be so much overlap. Dysphagia, they would have discussed there. Bleeding, they would have discussed there. And again, if you take stomach, again, a lot of cancers will be there. They would have discussed there. Peptic ulcers, they would have discussed in and out. If you go to the other portions also, it's very overlapping. So maybe what we can discuss is the IBD part, IBS part, or maybe the GRD part. So these are some areas with proper medical gastro kind of scenario, malabsorption. So these are some parts. Maybe we'll try to discuss that thing. Not a problem. Okay. Notes I'll try to send because I'm a little busy. Notes I'll do. Malabsorption I'll try to discuss. No problem. That's the easy one. Okay, I'll inform you in the groups when will be the next class. Till that, stay tuned. Hope the session was useful. We'll continue in the next session. Bye-bye.